Good evening, everyone. On behalf of the Indian Academy of Otolaryngology and Head and Neck Surgery, welcome you yet again to the GSK IAOHNS Webinar Series on contemporary ENT practice. So this episode will be on contemporary trends in the management of pediatric airway. This whole concept was the contemporary ENT practice webinar series was planned with the intention to update the common clinical conditions prevailing in ENT practice with a galaxy of eminent faculty. And we have none other than Dr. Deepak Mehta, who will be delivering the keynote address. Dr. Deepak Mehta is Professor, Baylor College of Medicine. He is the Director, Pediatric Airway Program, Texas Children's Hospital, President, Society of Ear, Nose and Throat, Advances in Surgery, 2017-2018. Over 80 peer-reviewed publications and co-founder of C Surgeries, a web-based surgical education program. Dr. Deepak Mehta will be speaking on contemporary trends in the management of pediatric airway. The moderator for today's evening is Dr. E.V. Raman, who is one of the pioneers in airway management in India, and he shall be taking over after the keynote address to conduct the panel discussion, where we have Dr. Amarnath from Visakhapatnam, Dr. Arpit Sharma from Mumbai, and Dr. Deepak Mehta has also kindly consented to be there to share his knowledge. Dr. Shashidhar Thatavarti from Gurgaon, and of course, I'll also be there as one participant. With these words, I welcome Dr. Deepak Mehta, and I thank him again for sparing his time to be with us and to share his knowledge with us. Please go ahead, sir.
Good evening, everyone. Thank you for the opportunity. Can you all see my screen? Everything looks okay?
Yes, sir.
Okay, good. Okay, so the way I'm going to do this is just giving you a brief on how airway surgery has progressed over the years and where we are now. So the pediatric airway surgery mainly came about for subglottic stenosis, and it's unique in kids, obviously, because the subglottis is the narrowest part of the airway, and also because of the advances on management of kids, things started to change. And the commonest cause for subglottic stenosis is acquired. And you can see this picture here. There's a congenital subglottic stenosis where you see an elliptical cricoid, and then you can have the acquired stenosis. It can be of various size. One of the things we need to be aware is that the airway keeps growing. So we need to be aware what size of endotracheal tube must be used for different ages, because it is very important as we manage kids of different age to be aware of the size. So why does subglottic stenosis happen? Some of the questions we know, some of them we don't know, some of them we speculate. So subglottic injury can happen just within hours. So we have seen sometimes kids, they've just been intubated for a short procedure and then they develop subglottic stenosis. So why does it happen in a small number of kids? And there are kids who have been intubated for a long time and nothing happens. So it could be that some of these kids have a little smaller cricoid and we are putting the appropriate size tube, then it causes the damage. Or it could be because of excessive endotracheal tube movement, or it could be tube design or superadded infection. So these are all speculation. Or it could be surgical factors if the tracheostomy was done high, getting into the cricoid, or there have been other iatrogenic causes like laser use. The other thing we have seen is the trend of subglottic stenosis over the years have gone down. In the 70s, it was high, and now it has gone down. But it is, again, difficult to quantify because it varies from institution to institution. It depends on the kind of neonates you take care of in different institutions. So it varies. What could be the reasons for the decrease in the acquired subglottic stenosis? One, it could be because we are more aware of the endotracheal tube injury. So we should use the ideal endotracheal tube is the smallest that permits adequate ventilation. So when you put a tube in, if you don't get a leak at 20 centimeter or 25 centimeter of water, that means it's too big, you go down on the size. Some of the other things which has happened is the endotracheal tube material has improved, which causes less irritation to the airway and less likely causes damage. The other things would be we are better at tube fixation, and also for long-term intubation, think about nasotracheal intubation. The main advances which have made a difference is a lot of these neonates in the past would have been intubated for a long time, but now with the use of surfactants and steroids, the duration of intubation has gone down. The other part is to keep an eye, think about how subglottic injury happens. So initially the endotracheal tube exerts pressure, then it causes ischemia and necrosis of the mucosa, ulceration, and then once there is cartilage exposure, it causes perichondritis, and then you have granulation tissue, collagen deposition, fibrosis, and contracture. It's important to be aware that this whole process initially takes about 3 to 4 weeks. And that becomes important when you're managing some of these airways. So that's why a lot of things we do in airway, we are looking at follow-up in 3 to 4 weeks, is mainly because this process takes about 3 to 4 weeks to happen. So things we don't know, or there are a lot of things we don't know. Some of things we have come along understanding, but we don't know. We still don't know why some kids get stenosis and some don't. Is it inflammatory cascade which happens in some kids? If that's the case, what happens, and is there some way we can stop that cascade? The other thing would be, can we detect this preemptively? Have some kind of nasal or tracheal swab taken, and that can tell us what's the genomics of those and which of these kids will end up getting stenosis. So those are things we need to know. Or are there any drugs? We know that steroids can help scar formation, but there's nothing much else we know that can stop the progression. So there's a lot to be learned from these kids who have stenosis, and there's more progress need to be made. This is a picture of mine with my mentor, Robin Cotton. And the thing what happened is he's the one who started to understand that, okay, we can do airway reconstruction in these kids. We can use a cartilage to make them bigger. But it is important when we do this, we do it as a multidisciplinary input. And then the management options depends on the maturity of the subglottic injury. So if you have an acute subacute injury, then most likely you can get done with an endoscopic procedure. Whereas if it is more mature, more likely will need open repair. When you think about airway reconstruction, you can mainly divide them into 2 boxes. You can either augment them, which is make the airway bigger, or you can resect or change the airway, take the bad part out and put the good ones together. For the augmentation, you can do a variation of different things. You can just put an anterior graft. You can put anterior graft with posterior split. You can do an anterior posterior graft or just a posterior graft. And same thing with resection. You can do a cricotracheal resection, or you can do a tracheal slide. And we'll talk about different situations where you do. And all these procedures can be either single stage or double stage. And single stage means the patient has come in with a trach or without a trach, but leaving the OR without a trach. Whereas the double stage is patient has come in with a trach or without a trach, but leaving the OR with a trach. And the trach will be taken out at a separate point. So the surgery for airway started off with just anterior cricoid split. So initially, people started doing anterior cricoid split. They were afraid what to do. But then Dr. Cotton had done some research on monkeys, putting in costal cartilage grafts. And then he started to see that a lot of kids who survived the initial NICU stay, but they got a trach and went home And believe it or not, the death rate was 25%. The kids went home and 25% of these kids died because of not proper tracheostomy care. So that we have come a long way from there. And more mainly it's from tracheostomy education. So he started using costal cartilage graft. And then once he started using it, then slowly it progressed to making posterior split and then using posterior graft. The other major change happened is with the management of these patients in the ICU changed, the thought of single stage laryngotracheal reconstruction happened. To save time, I'll just go through these little fast, but all these videos can be seen on the website C Surgeries. So basically the idea is to skeletonize the airway, and then you carve a graft, and you want to place this is the anterior graft placed into the airway. And the way it is put is the edge of that graft should be sitting in line with your airway. And that's how it's carved. And you see multiple sutures are put in to secure this graft so that it's nicely sit in. And it's very important to nicely secure the graft, that way it'll sit, and then it becomes an integral part of the airway. And that was the initial worry. When cotton started, people were worried that you're disrupting child's airway. Will the airway grow with it or not? What happens? The child might need more procedures later on in life. And at that point, the goal was mainly that if I can reduce the mortality from 25% to even by 5 or 10%, it's still worth it. So that's how it started. And once he started seeing success, and then he also saw that it was, he had not just success, but also was getting good outcomes from it. And a lot of these kids, when he followed up every year, the airway was growing with them. So that proved that you don't have to worry about the airway growing. And this is a video of showing a posterior split. And basically, when you're doing a posterior split, one of the things we need to be aware is this posterior cricoid has a more of a height compared to the anterior cricoid. So you need to visualize that and make sure you cut through the graft, cut through the posterior cricoid completely so that it opens up completely, especially when you're dealing with posterior glottic stenosis. You need to make sure you cut through that properly. Or if you're using posterior graft for bilateral vocal cord paralysis, even in those cases, make sure you come all the way up because you need to open up that posterior glottis. This is the progression of how ICU patients are managed. Some of these patients, you don't even have to completely sedate them. They can be awake while you're managing that. That's the progress which has happened in use of drugs like Presidex or it's dexmedetomidine, which can give you a good pain relief, but also does not cause respiratory depression. Double stage laryngotracheal reconstruction is still a workhorse. A lot of places that's commonly done, especially when you're not sure about the ICU care. It's okay to do a double stage as a safer option. The other thing, what happened was when after Cotton was doing all these procedures, it became obvious that that's a way to go. That was the only procedure being done. While on the adult side, cricotracheal resection was being done, and that was the main workhorse of airway reconstruction on the adult side. So what happened was, if you look at the results of the high grade 3 and grade 4 stenosis, it was not very good. It was still in 70s and 80s. And so what happened was, while this was going on, Philippe Monnier started doing cricotracheal resection in kids. And what happened was, they showed that it is very successful in high grade 3s and grade 4 stenosis. And the idea was, and they achieved 95% success rate in decannulation. And this basically was a changing time where people now started to believe that yes, cricotracheal resection is possible even in kids, and especially with very good results. So this is a animation from Cincinnati showing how a cricotracheal resection is done. So the anterior cricoid ring is removed and the disease part is removed, and then the posterior soft. So now you have exposed posterior cricoid. Then you use a drill to thin out the posterior cricoid, and then you get the two ends together. This is more of a technical surgery than the anterior posterior grafts in laryngotracheal reconstruction. So it has to be done in people who are more skilled. The other thing is all these procedures, it's better to be aware of different procedures because you might have to change things as they come along. This is an animation of a slide tracheoplasty. Again, it started off for complete tracheal rings where you widen the lumen of the trachea by cutting anteriorly and posteriorly and then sliding them together. So this way, you have a shorter trachea, but a much wider trachea. So it started off, when you think about it, it was an important moment in the management of complete tracheal rings, because before that, whatever procedures were being done, the mortality was very high, the success was not good. Well, since this has happened, the success rate is more than 90% in these kids, and these are complex kids. But also, so this is a patient with complete tracheal rings. They got on bypass. Here you can see the lumen of the airway is less than 2 millimeters. And then this is after the slide is being done. So it has become a treatment of choice for the complete tracheal rings. But what has also changed is the indications have changed. So in kids, especially little older kids with tracheal stenosis, even if it is a short segment tracheal stenosis, those are the ones where a cervical slide can be made. The principle is the same, where you cut through the trachea anterior posteriorly and then you slide them together. So in the past where tracheal resection was being done, it is a little better because you are actually preventing that stenosis happening at your anastomotic site by making it wider at the anastomotic site. And also recently there have been more papers, and a lot of these papers have come from Cincinnati. Mike Rutter is a big proponent of slide, and they've done some cases of tracheoesophageal fistula which has been repaired. I just had a case last week where there was a almost 2 centimeter hole in the back wall, which I managed to repair with a cervical slide. So it is a good procedure to have in your armamentarium. What has also changed over the years is ability to manage things endoscopically. There is a huge trend of having different things. The optics have increased, your telescopes have gotten so much better, you have other instrumentation, you have different lasers which can be used, you have the microdebrider, the balloons which were initially used by the cardiologists, now we have our own airway balloon. So this is a kid with grade 3 stenosis. You can see if it is soft, almost a pinhole. And this can be easily balloon dilated. And you can do it up to 3 times over a period of every 3 weeks. You can do them. Sometimes you can use, inject some Kenalog into that areas to reduce the scarring. But a lot of times you'll see the result immediately that this is opened up nicely. So it has become a good way to manage some of the acute stenosis. But also what has changed, when I showed you earlier that the subglottic stenosis, they started doing cricottracheal resection. When you look at the results of the laryngotracheal reconstruction, nowadays, I just looked at my series and we had like 96% success rate in just the anterior posterior grafts. And this is mainly because our post-op care has changed. We tend to watch them more closely, and we have different measures. So this is a kid who was starting to scar down, and what we did was dilated it, put one of the stent, and this telescope is going through the stent, and this basically the suture is going through the neck, going in through the stent, and you're securing the stent. So by doing this, you're leaving a stent for a little longer to help it heal, and then you can get the stent out after whatever weeks you decide that the stent needs to stay. So some of these endoscopic techniques have changed and have helped to salvage some of the LTRs which needed some time. And also the use of things like microdebrider laser have made possible some of these cases where you can manage them endoscopically. The other changes which has happened endoscopically is to avoid tracheostomy. There are endoscopic procedures can be done. This is the endoscopic anterior cricoid split, which I was the first one to do. This was a kid who had needed failed extubation, and the option would have been either to do a tracheostomy or do a cricoid split open. So we did a endoscopic cricoid split and then used the balloon to just stretch it open. And then we managed to avoid a trach. And now it is more commonly done, mainly in infants who are intubated and have glottic subglottic edema. And you need to avoid, by this procedure, you can avoid a trach. And this is a month post-op. The other situation where it can be done is in kids who have bilateral vocal cord paralysis. You can do an anterior cricoid split, and then you can do a posterior split, posterior split, and then keep them intubated for about a week. And there is a chance you can avoid tracheostomy in some of these kids with bilateral vocal cord paralysis as well. And you can do endoscopic posterior graft placement. So you don't always have to open up, especially in patients who have posterior glottic stenosis. Inglis from Seattle, he came up with endoscopic placement of the graft, and this can be done in isolated cases of posterior glottic stenosis and works pretty well. What's there in the future? So what we need to do is we need to, the pediatric airway itself is a comparatively much smaller field. So we need to keep an eye on what's happening in other fields, and we need to use those things to our benefit. And one of them would be, how do we prevent scar formation? So there might be a lot more research going on in scar formation for skin, for example. So we can extrapolate some of those findings and use that towards airway. And identifying the risk factors, which of these kids will end up getting stenosis and how we can modify the condition. So some of the things we know is fetal wounds heal with no scars. So some of those, we can use those findings towards our benefit. We also know that fetal wounds have different levels of TGF levels, and they have high expression of TGF beta 3 and low levels of TGF beta 1, beta 2. So maybe that's something we can target. The other thing which is big is use of bioabsorbable stents. So they are more and more 3D printed, 3D weaved bioabsorbable stents. So maybe we can use that, and you can use different technology which is coming along to make the whole thing endoscopic. So my thought is, if you can core out the scar and create an environment where new lining comes through, then you can avoid all the major surgery needed for these patients. So this is a cell frame technology where a bioabsorbable stent is made, and then you transfer it, the scaffold is transferred, and then you impregnate them with stem cells. And those stem cells, you see this is the naked scaffold, the electron microscopic view. And then after the stem cells are laid, you see that they start to lay down the extracellular matrix. And this is an example where it was used in in the esophagus. So esophagectomy was done, and then the stent impregnated with stem cells was placed, and then you could see that over a period of time, the new esophagus developed there. So that's something looks bright in the future. The other thing which has happened is, this is a case which I was involved in recently, where the kid had chaos syndrome, and typically either the kid would have died or needed an exit procedure. So we managed to fetoscopically do a balloon dilation and have placed a stent, and that way we avoided an exit procedure. And we managed to deliver the baby with a cesarean section. Immediately after delivery, we managed to secure the airway, looked at the stent, took the stent out, and were able to intubate the baby. So we avoided exit procedure mainly because the patient had a uterine condition. So there are things which can be done in the future, and it needs for us to just think of the different possibilities. And we have come a long way, and especially from the endoscopic point of view, we have come a long way in managing these patients very successfully endoscopically, and having the whole idea of using the open airway and endoscopic airway in total to improve the outcomes of the patient becomes important. And most of these videos can be seen on the website csurgeries.com. Thank you very much. If you have any questions.
Thank you, sir. Thank you, Dr. Deepak Mehta, sir, for your excellent deliberation. I do not see the question link. Tech team, can you just give me the link for the questions so that I can check it out? In the meantime, Dr. Deepa, has sir been able to join in?
Sir Raman sir has already joined.
Okay. I think I can hand over to Raman sir now. Yes, sir.
Thank you for standing by for me, Gautam. Deepak, apologies. A few minutes of your talk I missed in the beginning because of being held up in traffic after an important engagement that I had. And that was a wonderful roundup of the initial challenges we had taking care of the pediatric neonatal airways. And subsequently, of course, what we have managed to kind of standardize procedures for certain specific areas, but still a long time to go. And then the balancing of using the right instrumentation and also choosing the right kind of intervention, whether open or endoscopic in that particular situation, is important. And thank you very much for all the futuristic ideas that you said are under development. Beyond that, is there any question, Gautam, you can see on the list that we can ask Deepak right away, or maybe we can cover during the panel? I mean, it's left.
So once we get the link, we'll pass it on, pass the queries over to you, sir.
All right, fine, fair.
Vijay says there are no questions as yet.
At the moment, okay, fair enough. So maybe we can go on to the panel discussion, and we can have, of course, Dr. Deepak Mehta has been a major supporter of our airway venture, which we started many, many years back. It's almost 22 years since we started our airway work in our center. And Deepak has been the anchorman, and we thank him for that. And I'm happy that he's with us. Thanks to the updates that we've been having over a period of time in this area, specifically dedicated to a very niche area of airway and airway and swallowing disorders, we have an excellent crop of doctors from India who have trained locally or trained abroad, come back and doing excellent work. And I'm so happy that we have an entire group of, representative group of this generation. That is, Dr. Amarnath is here with us. He is probably the newest kid on the block. I'm not too sure. He must be the newest kid on the block. Welcome, Dr. Amarnath.
Hello, sir.
And,
Thank you.
Dr. Shashidhar, of course, if any new innovation is going to come from India, it's going to come from Shashidhar. He's a man who thinks out of the box, and let's see what kind of an interaction we have with him today. And he's very enthusiastic. He's been, I can tell you, along with a couple of others, partners in the crimes that we've been committing for the last 22 years. And we've learned a lot from each other. And of course, Dr. Arpit Sharma, coming from Bombay, is another enthusiastic, well-trained airway surgeon. And we hope to work more and more with him. And Dr. Gautam Kond has an excellent team in Guwahati. And again, when I went there, all I can say is every time I go to these centers, I think it's like mercy twice blessed. Both of us learn newer things. And of course, Deepak is there with us, and he shall continue to be a member in the panel, and he can always give the expert advice because of his extensive experience. Now, we start off, this particular program is basically for general ENT surgeons who may or may not be doing airway work, but then airway work will be thrust on all of us at some time or the other. So we need to know the basics and also go ahead and build our skills over a period of time. So this is going to be basic questions, and let's start off with the first one. Let's start off with the history. Dr. Amarnath, if you can just tell us, when you see a child or a patient, there are 2-3 scenarios in which we are called. One is, of course, the child might come directly to you. Other one is the child is in the emergency room, or the child is already in the neonatal or intensive care setting. And what are the important things that you need to kind of ask or look for in the history of a child with noisy breathing?
Thank you, sir. Actually, I usually go to the ICU setups to see the patient, to the child who are already been intubated, because I go for more of a referral centers. So where I usually ask for the onset, like what was the intubation history, was there any failed extubations, and how was the cry and swallowing difficulties the child was having, or feeling difficulties. So these histories also with change in sound of the cry or voice, and also aggravating or living factor based on the body position, whether it is associated with lying down or prone or proper supine position. And also from the parent, they would have observed clearly from the child what are the possibilities, what they have expected all these days when they have seen the child suffering.
Arpit, would you like to add something on basically the history, which you think is important as far as the initial assessment is concerned?
Yeah, so the most important part is the onset, age of onset of the symptoms. In which condition, is it supine or the prone, what kind of a breathing the child is having? Is there a stutter or more of a stridor? Or if parents are able to visualize any kind of a retractions on the chest, especially the suprasternal or the subcostal retraction. And about the feeding also, when the child is feeding, is able to feed at length or is not able to feed also, sometimes struggling to feed and breathe also simultaneously. Apart from that, is the child weight is corresponding to the age or not? Apart from that, is there a frequent respiratory tract infection that is happening, history of repeated hospitalization, if at all is there, if any other procedures that has been done in the immediate soon after birth, like maybe just to rule out any congenital conditions, or any other syndromic situations, if at all child is having a history of. So all of that gives a good idea, a fair amount of idea, what the child may be having. And yeah, that is the most.
Yeah. So Yeah, all the points raised by both of you are absolutely relevant. So we're going step by step. Initially, we thought we'll go to the history as the point, and this slide actually is just put up to summarize what you've said up till now, both of you, so that our audience gets an idea of what are the important points. So I'll just go through them. And when were the symptoms initiated, the duration of the symptoms, or when the episodes repeat themselves, whether it's an episodic problem or whether it's a continuous problem, whether the symptoms are worsening, whether they're steady or have improved over a period of time. And of course, as Arpit said, weight loss, failure to thrive also gives us the idea of the severity of the condition, associated feeding difficulties, intubation history, prior surgeries, neurological conditions, whether any syndromes are associated with it or any genetic issues that we need to address. Now, Shashi, can you just go back to the old slide, Deepa? Shashi, would you like to add anything that we've missed out, or you think we would give more importance?
I think a lot of things you've said is absolutely great, but nowadays we say take a video of the picture, because whenever the patient has tried it helps you to document it, and also, for diagnosis and later procedures. And pulse oximeter is also important because a lot of people now have it at home because of the COVID. Even the watches have it. So even a very common watch for 3,000, 4,000 gives you a sleep pulse oximetry actually. And there is a Megel score for that. If you have a raw data, you can actually take a score. But we can use even this basic technology like cell phone recording and this to augment what we are hearing.
Thank you, Shashi. Very important points. These two, no matter how well they describe the problem, I mean, if we have the video and it's ready-made the moment they come, and in the recent past, I'm sure you've also noticed the parents themselves come and say, I've got a video of the whole episode. I agree with you, and the availability of oximeters. So whatever information you can collect in the first instance, even before doing anything, is very important to place the child in a particular group. And Gautam, you want to add something? What happens in Bhubaneswar, in Guwahati? I mean, you're muted.
Sorry. I think all the points have been fully covered. I mean, what Arpit has also talked about, the feeding difficulties associated choking, etc. during feeding, or is there any cyanosis during feeding? These are other points that we need to talk about. And I think it's been very well covered. And what Shashi has also mentioned is something we also have started insisting on our patients to take a video, and that helps us a lot in assessing whether it corroborates more with their history that they have given us.
Yeah. Deepak, you want to add something?
The main thing I would add is you need to divide all these patients into two big groups. Number one, is this kid's airway impending danger? So the kid in his extremes, you have to manage it very differently. So those are the kids where you will see all the accessory muscles being used. The kid might look toxic. The kid might be in a certain position. Sometimes they'll be in a tripod position where they're leaning forward and putting their hand in front, or they might be extending their neck to open up the airway. Those are the ones where you have to think about securing the airway as soon as possible. And the other ones you need to be careful is the kids who have been working hard and now they are tiring out. So they might slow down, their noise will be going down, but they might certainly go down. And those are the ones you need to rush in to secure the airway first while you're looking for everything else later. The second group are the ones where things are more stable, where you have to go through all the steps you're talking about. Then those group, you have more time to look into what are the possible causes and take it from there.
Excellent take-home point. The evaluation, especially starting off from history, is to slot the child, triage the child in such a way that whether the child requires immediate attention or you can take your time deciding what exactly is to be done for the child. So you kind of separate these two arms of the from the history taking it. So that is important. Secondly, many times, as Deepak did mention, that sometimes you get a news that the child had noisy breathing, but the child is much better now. You don't know the condition of the child. Maybe the child has become worse. So please be aware of it, and your team should know that there's no sound that is also dangerous. The child has stopped breathing, or the breathing has been affected. So the next slide will tell us about these concerns. So we have age of onset in the history of atresia, vocal cord palsy, laryngeal web and stenosis, vascular ring cystic lesions could manifest themselves in terms of complaints at birth itself. A few weeks later, maybe you think of laryngomalacia, tracheomalacia, or subglottic stenosis. And 1 to 4 years, maybe the child could come his history of recurrent croup, epiglottitis, or foreign body aspiration. Of course, we're not going to cover foreign body today. That's outside our purview as of this particular session. So infective, inflammatory, and anaphylaxis can happen at any age. So these things give you an idea of what's happening. I think one thing we've missed out here is probably subglottic hemangioma, I think, in the slide. Yeah, we have. So that also presents a little later, not immediately, maybe around between 2 weeks to 2 months time, I think. Yeah, next slide. So we have to decide on the course of action, and history is very important. And based on the history, we need to choose the investigations, decide on the diagnosis, and initiate management. This was outlined to some extent by Deepak. Let's go into the details. What are the investigations? Okay, let's assess the child with breathing difficulties. Yes, go ahead. So how are you going to assess? It's going to be a repetition, a little bit of repetition. Maybe I'll ask Arpit to tell me about this. So Deepak did mention about slotting the child into immediate attention or later attention. So once you've done this, are there any other things that you're going to keep in mind, especially in terms of the breathing part?
So definitely when the child is coming to us in the OPD, we would like to have an examination. And usually most of the, like in the infants, we are able to have a flexible examination then and there only, awake examination. That gives us a fair bit of idea what exactly we are dealing with. If required, then we will definitely take the child for a examination under anesthesia. That is going to be a kind of a flexible assessment of a dynamic airway. The child is going to be put to sleep and going to be mask ventilated, the sevoflurane on and a propofol, so that we can see what exactly is happening when the child is kind of asleep, what kind of a movement the pharynx and the larynx is happening, what kind of exactly is happening in the airway. After that, we can go for a rigid endoscopy also after paralyzing the child. So this is going to be the usual assessment protocol. We usually don't rely so much on the radiographs or the CT scan or the MRI till now. Mostly we try to do a dynamic airway assessment and the rigid endoscopic airway assessment.
Right. So what we'll do is we'll put up the next slide and then ask the comments from the panelists. Can you have the next slide? Yeah, so when we see the child, we have these airway concerns. And as you can see, we need to, do you want to comment on this, Amarnath, Dr. Amarnath, anything you want to say, looking at this slide?
So we have an idea, sir, actually, from what will be the cause for the child with the breathing difficulty. But this will really help us to guide what was the situation and how to proceed forward, whether to investigate or do endoscopy earlier or to secure the airway immediately. Based on the stridor or a stutter, we can identify saying that, okay, this child is having kind of stutter, so we can wait and we can do some endoscopic evaluation. But the child is really in stridor, that we need to secure the airway immediately.
And so you'll basically, regarding the voice and the feeding, how do you go about it? You ask some questions or you have somebody observing the feeding? What do you do?
Yeah, that's what. For voice and breathing, so first voice is like, what kind of voice is a feeble voice, or is there any hoarseness of voice or something? And we a sudden loss of voice again. And with respect to feeding, like we can ask like feeding the difficulties like signs of aspiration, cough. These are the signs which we can assess. Like even we can diagnose like something happening at the level of glottis.
Right. Shashi, any comments on the slide regarding the concerns that you have to have in your mind when you examine the child?
Yeah, I think Shashi, I can come in till Shashi is connected. I think he's got a network problem.
Okay, yeah, go ahead.
Sir, I would actually, before talking about investigating, I mean, putting in a scope or looking inside, I'd say, I will tell a person who is not doing airway regularly, or even a person who is into airway management, to first observe the child, because observation is the most important thing. Then don't immediately touch the child. The child is lying in a cot, or the child is in the mother's or the caregiver's lap. You observe the child. You try to correlate the history with the what your observational findings say, how much exercise Dr. Deepak sir has said about how much the accessory muscles are working, whether the child is a little blue, or does the child look very tired, as you had mentioned that this is a dangerous sign because we might lose the child. Then we look at the intercostal retractions, etc., and try to estimate whether it's a strider or a starter. And also we try to differentiate whether it's a child who requires an immediate assessment, immediate management of the airway, then assessment of the cause, or this is a child where we can go slowly with the assessment proper and then try to plan the treatment. Because sometimes in some children who come with a lot of stridor, our first aim would be to secure the airway, do everything else later.
Right. Deepak, since we are addressing this to basic ENT surgeons, would you want to add on something in terms of this particular slide, which tells us what all to look for?
Yeah. So Gautam sir made very important point. It's very important to just see the child. So once you have seen that they are not in danger, you need to just assess. A lot of times, just the kind of sound which is coming out will tell you the diagnosis, and the age of the child will tell you the diagnosis. So if it is a newborn child who is struggling to breathe, then you know most likely it is choanal atresia or maybe vocal cord paralysis. But those will be your few things which will happen. The other thing is it definitely stridor? Then you need to say, look at it while breathing. So you're seeing whether it is inspiratory stridor, if it is expiratory stridor or biphasic stridor. If it is inspiratory stridor, it means it's mostly glottic, supraglottic problem. If it is biphasic, it's mostly subglottic problem. And if it is expiratory stridor, then it's mostly tracheal or beyond problem. So it gives you a fair idea to start off to say, this is what probably I'm looking at. The other thing is feeding is very important. So to see what's happening with feeding, because the newborn baby or all of them have a suck, swallow, suck, breathe, swallow pattern. So when that pattern is affected, their feeding is affected as well. And that's the reason some of these kids, either because of their increased work of breathing or not able to feed properly, they'll start to lose weight. So you will be seeing that. So, and also in relation to feeding, what happens? So if you see them coughing and choking with feeding, or if you're seeing that they have congestion right after feeding, that suggests that they might be aspirating. So those are things which we are looking to say, okay, then likely there is either a laryngeal cleft, a T fistula, something like that, which is making those symptoms. So these are things where you can get a fair idea of what you're dealing with without doing anything, just by observing the child and asking a few questions.
Wonderful. Arpit, you want to add something?
Not really. I think everything has been covered.
Most of the
Only
things,
thing
yeah.
is only thing is whenever we are doing this assessments, we should keep everything standby. All preparation should be there. If required, if we are doing a rigid examination, rigid endoscopy, if the child airway is worsening, we should be prepared to do a tracheostomy. So we should always be in a full ready status. Basically, if required, we may need to intervene then and there only. And if required, secure the airway by intubation or a trach, we should be ready to do so.
Right. So mostly there are three scenarios. One is child coming to the outpatient, child coming to the emergency room, child already in the hospital and you're called to the ICU. But in all those cases, you never know. You might require some kind of an airway support. So be ready for it is what I think I understand as Arpit is saying. That's important. And as far as stridor is concerned, inspiratory, expiratory, yes, biphasic. But then there's one more thing, that any fixed obstruction anywhere in the respiratory tract could give rise to. It's not sacrosanct that inspiratory is cord and above, and biphasic is cord and just below, and then the expiratory is from the chest. But biphasic stridor could come whenever there is a fixed obstruction at any of these sites. That's one thing I just wanted to add. So let's go to the next slide and see what we can get from our experts here.
So 1 minute.
Yeah, sure, sure.
Dr. Shashi is back. He's connecting.
He's back. Okay. Shashi, we're just discussing we're just trying to. Yeah,
I was, so like I said, what Arpit was saying, we have started using fiber optic as the #1 tool, as in to augment even the first impression. So whether it's emergency or the ICU, it is such a simple examination like a tongue depressor now, that if we don't even take consent, even the bad striders with a 1.9 mm scope, chip on tip, you actually get a very good clarity of the information. So when we were doing residency, we were taught not to touch a child, and a lot of time would be actually wasted in getting a CT scan prepped up, or X-rays or other investigations. And I also like the idea that you are using ultrasound also, a very non-invasive methodology in the first primary encounters.
I agree, Shashi, with all the observations that you've made. But as we are talking to a general ENT surgeon, when a patient comes, we wanted to go step by step. And some of them may not have the equipment, what happens, or they may not have, passing a scope is one thing, interpreting is another thing. So unless they reach the level that you are at, where by instinct, because of your training and your exposure, I agree what you're doing is absolutely fine. And the tolerance limit for a flexible scope is very low. You want to do it quickly and come to a conclusion. But a general ENT surgeon seeing these things, we were just trying to reiterate that, just seeing the child gives you ideas, history gives you ideas. So you need to find out which category the child.
The reason I was saying is because the whole practice goes to all new level once you get the flexible scope. I've seen one of the best centers investing in good equipment, but not investing in a good fiber optic thin scope.
Well,
it goes about lasers or any other thing if you have a good diagnostic tool. That's just the point which I was.
Yeah, absolutely. Taken in the right spirit. What you're saying is absolutely right. I couldn't agree with you anymore. So that's it. So you start with the history, examination, and that those things give you a hint. And if you have a scope available, seeing is believing is what we keep repeating. It's much more valuable than anything else. And once we get the skill, we use it much more universally rather than sparingly. So again, going back to what you people have already said, we need to understand, you'll be surprised, many of us don't even think noisy breathing is just stridor, and we don't even try to differentiate between stertor and stridor. And we need to highlight this, that all these three things are different, and they give us a lot of hint as to what is causing the problem. We'll go to the next slide now. So this is also very important. This insight, I think you should have if you've had enough, exposure in the emergency room or the pediatric ICUs or neonatal ICUs. These are all important things like the respiratory rate and added sounds, stertor, etc. Instead of reading out this slide, I would ask each of the panelists just to go through this slide and comment on this. So this does give us some clues regarding the management. Dr. Amarnath, would you like to say something about this, the assessment of breathing per se?
So actually we can grade based on grade 1 to grade 3 based on the severity of these symptoms. As Deepak sir said rightly, like if the child is in grade 3, that means like the child is not breathing at all, the child is already in exhausted stage. So these sort of grading has to be done based on these symptoms like respiratory rate, axonal muscles, how the axonal muscles are used, flaring of nose and the color of the child, and also heart rate, saturation. So these are most important. I usually ask most of the hospitals to have this chart in their ICU setup and even operation theaters also, because this is what we can write easily. And this is one of the excellent tool to take the main high risk children of prior who needs a priority on the treatment.
Right. Any comments from Arpit?
So I think we have already covered the position of the child, the flaring of the alar nasi, the retractions, suprasternal, the subcostal. We should always examine the child without any clothes, basically, to exactly having a look at what kind of a retraction, how much child is gasping for breath or struggling for breath, if at all. And definitely the color and the respiratory rate and the heart rate also gives a good indication of what is exactly how much child is struggling or how much is comfortable. Apart from the stridor, stutter, the noisy breathing that we are able to listen.
Right. So next slide, please. So there is a situation sometime where you're called into the intensive care or even the pediatric emergency room where they have a problem, can't intubate, can't ventilate. So do you have a set of things which are ready so that you can mobilize everything in a few seconds, a few minutes? What are the things that are important that you would say you need to keep ready? So what we'll do is, I think we have to put up the slide that makes it easier to focus on what we are talking about. Do you have a slide after this? I think we have one. Yeah. So can I ask Shashi? So when you go to see this kind of a child, what are the things that you need to have with you? And what are the things, how do you think about these things? Here's a full-term uneventful neonatal period, no cry at birth, failed bag and mask ventilation, failed intubation, failed LMA. And sometimes these children also, by the time you see them, they are very critical and one can have things like rare conditions. I think we won't go into that. Let's go back to the previous slide and talk about what are the things you'll keep ready. Can you go back to the previous slide? Yeah. So what are the things you would keep ready and what are the things you would anticipate and see the child? Shashi?
So one of the fundamental things when you're going to assess, you may not get time to even arrange a fiber optic. So you'll have to examine with a direct laryngoscope. So Macintosh with straight blades, pediatric sizes 0, 1, 2, 3 is most important. Second, you need to have bougie, especially the very flexible aluminum bougie, because a lot of times an ENT is a better person to intubate than an anesthetist or a pediatrician. And once in a while, you may encounter a cyst or a valvular mass or a lesion, and which may obscure your intubation or your airway assessment. So you should be prepared to, even if you want to aspirate and reduce the swelling, you should be able to have a syringe. And then you need to have a tracheostomy set standby. That's a mandatory thing with the correct tracheostomy tube, because 3.5 tracheostomy tube is always difficult to procure in normal settings. So you need to have that in the standby. And ET tubes are various sizes, 2, 2.5, 3, 3.5. And it's easy to have uncuffed tube, because to get a cuffed is another big job. You easily get an uncuffed tube of these numbers, but not the cuffed ones. So be prepared with the cuffed tubes. And lastly, when we are not able to do it, it's good to have more helping hands. I call the anesthetist, page the anesthetist, because a lot of times they may be associated anomaly, because no voice at birth is vocal cords, web, or tracheal stenosis or a subglottic stenosis, which is very, very severe. So these are the conditions. So you may have to do a low down tracheostomy or suddenly try to do something. So at least you need to page up and tell the OT to be ready while you're trying to buy some time here with the kid.
Excellent points. Mobilize for help, mobilize for assistance, and use your skills. After all, when you've been doing so many bronchoscopies and laryngoscopies, you're probably very well equipped to intubate even in those difficult cases where the others may not have seen these variations, etc. Deepak, you probably have your whole Airways Aerodigestive Center army of younger ENT surgeons who face these problems. How do you kind of train them to be prepared for these kind of situations? What is your advice to them?
So number one, I take all the points that she said. Those are all very important points on how you go about it. Number one, the fact that the child was able to be born means there was an airway. Otherwise, the child would have, it wouldn't have been viable. The fetus wouldn't have been viable. So the fact that the fetus was delivered means that there is some airway there and something else has happened. So the next point is, when you have that situation, it depends on who is doing it. A lot of times panic sets in as soon as they see that the child is going down. So you need to be the calming factor to say, I can help you out here. And like Sashi said, have the appropriate blade and get an exposure to see what's happening in the larynx. And if you can see the larynx, then you need to have the different size tubes and you intubate. In our setup, we have what is called as an Airway Card, which has pretty much everything you need for securing an airway in one card. And as soon as we have something like that, we have that ready in 5 minutes. It's next to the patient in less than 5 minutes. So that's how it's set up here. But you don't need to have that. In that situation where you are, you just need your endoscope and different size endotracheal tubes ready, and then you can go. If you have, say this was a little, give it a little different scenario where the anesthesiologist was trying to intubate and can't intubate, but the child is a little stable, then you have time, then you get more help in the sense you have a ET, the rigid scope, you can load your endotracheal tube onto a rigid scope. It could be because the kid has Pierre-Robin sequence or kid has laryngeal web, and that's the reason the kid is having issues. So you need to be ready with different size tubes, and the way Sashi said was very well said. So I would just go with what he said.
Fantastic. I think we've kind of summed this up. You must make do with what is available immediately. And if you are a well-organized center, then it's better to have a cart there where most of the things which are required are kept ready so that if 3 o'clock in the morning or 2 o'clock in the morning, you don't have any problem. So this is one particular case we saw. There's a non-canalization and causing chaos in that child. This was the pre-exit days, so we didn't do an exit procedure on this particular child, but then you may have to do a prenatally diagnose and then probably take care. That's one of the options that we have. So let's next slide.
Dr. Raman, I'll just add that the fact that this kid was born,
Right.
You should still be able to intubate either with a 2 or a 2.5 endotracheal tube.
Yeah, so let's go back. Yes, there was we didn't show you the full picture. We kept part of it. There was a small opening, the back, which is not seen here. We've had more than one case of this type. One we had where the child had a tracheoesophageal fistula, and the child was breathing through the tracheoesophageal fistula. So you have variations and combinations. So just to represent sometimes, yeah, go.
That's the beauty which I was asking anybody would tell it. So the combinations are can't intubate, but can ventilate.
Right.
It is basically Pierre-Robins or micro glossoptosis, and one of those things where you can't put a tube, but they're getting
Exactly.
The other one can intubate, can't ventilate, which
Right.
would be a T fistula and everything. So there are 4 or 5 combinations, scenarios, and we need to know all of them.
Right.
I would like to add.
Yeah. True. There's various degrees. You're absolutely right. I agree with you. You want to explain that, or I think it's already quite apparent, isn't it?
Can I add something?
Yeah, go ahead.
So especially in a Pierre-Robin syndrome, it's very difficult even to visualize with the endoscopes also.
True.
So it is, I think, one of the most difficult situation to intubate. I feel in certain situation, in such child, if you kind of try too much, again, you are increasing the airway edema.
Right.
Sometimes retrograde intubation by putting a catheter through a needle into the subglottis and passing a very thin catheter and railroading the tube through that can be very useful. I have seen
Right.
in 1 or 2 cases like that, put in a wide bore needle in the thyrocricoid membrane and slide in a catheter which comes out into the pharynx, and you retrieve the catheter and railroad the tube through that to intubate the child.
Wonderful. Anybody else wants to comment?
So we use fiber optic intubation that almost helps. The second word is to railroad your ET tube on a 2.3 mm endoscope, rigid endoscope. And as you just see the larynx, just pass through the vocal cords and then use that as a guide to intubate it. These are the two places. Retrograde, I haven't tried, so no experience with that. But flexible fiber optic with changing the position and using your left hand to intubate and the last second finger to press on the cricoid. When you press the cricoid yourself, you exactly know how much to press. And that's when the visualization is the best. But if you ask somebody else to press the cricoid of the neck while you're trying to visualize the larynx, it is almost always you're trying to readjust and it never happens. So this is what Dr. Rutter always used to talk about when intubating a child, that there are 3 maneuvers of how to intubate a syndromic child. One of the most important is use your own finger for cricoid pressure.
Right. Thank you. All, I mean, everything is, all the points are very relevant. But then, here, Robin, again, there are difficult cases where things are extremely difficult. One of our cases, I remember, we couldn't see it with the technique that you were talking about, Shashi, where we use a 0 degree and look at the larynx. We had to use a 45 2.7 to have a look. And we had a wonderful anesthetist around. Jayashi was there and we managed to see it. You're looking in one direction and then using the tube in the other. So these are all various methods by which we can secure the airway. And the important point is like quickly determine the level of the airway obstruction and bypass the lesion in whichever way you want. And I think Arpit gave us, I mean, I'm hearing that for the first time. So maybe in some difficult cases, we can use his advice. And we have to secure the airway. And most importantly, call for help when in difficulty. Don't go on and on. There could be somebody, could be a new kid on the block, your own assistant who might finally manage to secure the airway. Right, next.
Dr. Raman, I'll just add,
Please.
Pierre Robin comes in different ways.
Yes.
So a majority of Pierre Robin are mild to moderate. Those ones you probably don't have to intervene at all. So we need to be aware of the patients where you can manage just with conservative treatment, which might be just positioning the baby, letting the kid grow. A lot of these kids, as they grow, they'll get better. The other thing is just getting a nasopharyngeal airway in some of these kids, where you put a nasopharyngeal tube, which can push the tongue forward. By that, you can improve the airway. And if you see things are getting better with that, then those are kids, again, you can let them grow and you can avoid any interventions. The third group are the ones which are more serious, more severe form of Pierre Robin, is where you might need some kind of intervention. My only thing is, with what Arpit said, I have one concern with that. If you have that much of a difficult airway, then you are better off, and you manage to ventilate that kid, you're better off doing a tracheostomy. If you're not confident in intubating, then while you're doing all this, what is the end result? Even if you manage to intubate, what will you do afterwards? Because this kid is not going to be extubated. So you might as well just do a tracheostomy at that point, because that way you have more secure airway and then go from there. The situation where you are able to intubate from above with either with the fiber optic intubation or with a rigid endoscope is where you just need to have a decent exposure to be able to see. And then if you can intubate, then you can do that while you're figuring out what else needs to be done, because some of these kids, you can do a mandibular distraction to avoid a tracheostomy. So if you have all that stuff available, then you should do that. If you don't, and if you're struggling, then you're better off at that point to say, let me do a trach, create a secure airway, and then we can figure out what else to be done.
That's absolutely fantastic advice. Basically, going back to Mosier's dictum, when you think of a tracheostomy, just do it without wasting time on anything else. That's something that you need to fall back upon. And I think that's good advice instead of tinkering with a newborn's airway. Can we have the next slide? Yeah, this question has been answered, I think, in multiple ways. And it's becoming almost like when you think of a flexible, go ahead and do it. But in the practical aspect, when you're in the hospital, depending on which hospital you're in, what equipment is available, and the parents agreeing for nasopharyngeal laryngoscopy, you have an established airway center like Shashi or Arpit, maybe they just tell the patient they already referred, they already primed, you go ahead and do. But we have different kinds of patients coming to our hospital. Some are referred by somebody, or sometimes they just come and they're not willing for any kind of intervention. So we have a list of indications which we are putting up here, which I think most of you will agree with, but still we'd like your comments. Let's have the indications one after the other. So I guess all of us know that if there is severe stridor or progressive stridor with associated with unusual features, cyanotic attacks, apneic attacks, dysphagia, aspiration, failure to thrive, radiological abnormality. And the last one is equally important. I've had a couple of patients coming and telling us, I really want to know what's happening for my child. So parental anxiety. I think most of these things, all of us will agree with. And Shashi, I take your point that whenever you feel, so is that something that you follow? The moment they come, you say that we need to do a flexible, and then you explain to them in a proper way, and then of course take their consent. Most parents agree. Is that what happens in your setup? Hello? Shashi,
Yeah, sorry, I unmuted myself. So
Oh.
if I'm going to examine below the level of the larynx, then I take a consent. If I'm just going to be above the larynx, I generally do not, because I just tell them this is a part of examination.
Okay.
And the point here is, if you're charging them, then there's a whole lot of procedure to be followed. You need to generate a report, and you have to take a consent, and you have to follow the protocol. But it is my curiosity, what is wrong with this kid? So the scope is always there in the OPD, and we just decongest the nose with a cottonoid placed for a few minutes with xylocaine and xylometazoline, and then we just examine it. So we have done a thesis on kids as young as 1 to 3 years. The acceptability was surprisingly very good, and the parental anxiety was much less when we told this is a part of normal examination. But when you make everything as a procedure, and the anxiety also increases, they call up people, they want to ask, they want to know, and that also delays it. So a lot of times when I know I have to go below the vocal cords, then I usually follow all the protocol and do it. The biggest crux here is the infective patients. If they are having a croup or a bacterial tracheitis, or epiglottitis and other things, do you still want to do a fiber optic or not? And that's a very controversial issue. I generally want to do it and confirm it, but I would be very, very careful not to irritate the child. That's like the fundamental. I would not even give it to my subordinate to do it. I would do it myself, because I know where to stop. But if child is having stridor and there is an infective indication, it is not a contraindication to do a fiber optic examination. That's one small point, because if there are thick mucus in a bacterial tracheitis, you have to take the child for bronchoscopy and clear out all the mucus crust. So even that is a life-saving procedure, which is an infective indication, actually.
Dr. Amarnath, any comments on when you do what is practiced in your place? Each one of us are working in different locations, different cultures in a way, acceptance of procedures. What are the things that you have?
Thing is like,
comments-wise.
yes, sir. Whether I charge, I don't charge, but I used to get consent from the parent.
Right.
Number one. Number two is like I usually explain them, but I will never do flexible endoscopy for a child in my OPD setup. I used to take them to the operation theater in the presence of an anesthetist, because I communicate to the anesthetist. I say I have to go see the airway, including, if possible, if I need to go to the vocal cord level and below the vocal cord levels also. But
Right.
I confirm, I prepare the patient, even the anesthetist, and well communicate both of them and get a proper consent from the parent, and then go ahead with the procedure. But
Right.
other rest all I do accept with Dr. Session.
Right. What about Arpit?
So definitely the OPD examination with flexible is the norm, and it helps actually the parents accepts whatever they are seeing. Secondly, it's easy to counsel them also. If you tell
Right.
them you are going to take the patient in the OT and you're going to do under anesthesia,
True.
most of the time they say, they are not comfortable with that.
Right.
And they don't want the child
Right.
to be anesthetized or intubated, if at
Right.
all, if required. So once you do the flexible in the OPD, then they see the situation also themselves. Okay, it is. Then you can counsel them further. Okay, patient do require further examination in the OT. Then they also kind of agrees to it if required.
Gautam, what do you practice in your place?
In our center, we do with the OPD. We have got the endoscopy suite. So we have the pediatrician who comes in along with the ENT guy. So
Okay.
both of them are there. So
Right.
that is a big help, because we don't need the anesthetist for any untoward incidents, because
Right.
we are monitoring. We have the pulse oximeter in place, and so when we do a TNFL, we do not stop at the level of the larynx. We go through, we do the full examination, because you might be missing out some second pathology. You have a laryngomalacia and you stop there, you might be missing out something lower down in the trachea or in the bronchus as well. So when we examine, because it hardly takes some time, and we record everything.
Right.
We record everything. So you do it quick, can you see the recording? So that
Right.
helps.
Right. I think what the others were saying, more like a screening procedure in the OPD to do that. Deepak, what do you follow in your place? Your place is very structured and sophisticated. What does an average ENT surgeon faced with this do generally, and what do you do in your place? Both of them.
I'll tell you a story. When I first started in Pittsburgh, Charlie Bluestone was there,
Right.
and he was of the belief that you shouldn't be doing flex scope in the outpatient at all. Every patient has to go. So this thing is not new. People were worried. There were two camps until recently. Now I think it is standard of care that you do a flex scope in the outpatient.
Right.
The main thing you need to realize is, if this kid is otherwise normal, in the sense not in extremis, and has stridor, intermittent stridor or stridor, you won't cause laryngospasm or anything like that.
Right.
So you don't have to worry about that.
Right.
Doing a flexible scope is as good as, like Shashi earlier said, it's like putting examining the throat with a spatula. So it is as good as that. So I just warn the parents, I don't even put anything in the nose. I don't put local anesthetic. I don't put decongestants, nothing. I want to see as it is. And again, it has been shown that whether you use local anesthetic or not, the amount of discomfort is just the same. So I just warn the parents that the child will cry for a little bit. It takes 15-20 seconds for the whole thing. The whole thing is recorded. The parents can see the whole thing. You just do it 15-20 seconds. You get a fair idea. You come out, you can explain, and then you can decide whatever the other things are. The only thing I'd be careful what Sashi was saying about infective patients.
Yeah.
If the patient is in extremis, I would say it's not worth looking. Just take them to the OR. Even if it is bacterial tracheitis, that kid needs intubation. So why are you putting that kid at risk that you are aggravating things? Those kids, I would just take them to the OR and do the exam there, and then intubate or whatever is needed. These are kids who are toxic and look in extremis. I'm not talking about kids who have a little bit of croup-like symptoms. Those ones I can argue whether you should do a scope or not, because they'll get better. But the ones who are in extremis, I would just take them to the OR.
So one confession, 22 years back, whenever I started my work, I used to use the adult nasopharyngoscope through the oral cavity and have a look at the larynx, like a screening. That's how we started. Now we have these smaller scopes, which you can do. But as a screening procedure, when you want to make sure what is the, I mean, you need to take the child to the theater or not, or whether you just want to do it as a screening procedure, it makes sense. And I think there are people who do it in the OPD, which makes it much easier. Here we have non-nutritive suction. The child is quite comfortable, nicely draped, and you can have a good look. And like they say, a picture is worth 1,000 words. So you can quickly screen for cysts, for webs. Palsies might be difficult to see, diagnose in this condition. At least you have an idea of what's happening, and then you can plan later. I think all the points taken from all the people is, I mean, considered very relevant, and thank you for your inputs. Can we go to the next slide? Now, there are situations when you have to take this kind of decisions for tracheostomy, sometimes absolutely emergency, or sometimes it's quasi-emergency planned kind of a thing. So what in your experience has been the common indicators for taking up a child for tracheostomy? Can we start with Gautam? I mean, in the recent past?
In the recent past, the only situation where I had to do an emergency tracheostomy, where the foreign body I was extracting, a seed slightly large, which got stuck in the subglottis, wouldn't go down, wouldn't come up, and I had to do emergency tracheostomy. That was the only recent situation where I had to do emergency tracheostomy. Otherwise, my experience on emergency tracheostomy is very limited.
So let's take tracheostomies in general. I mean, what have they been indications? Emergency or even planned?
Planned tracheostomies are where, again, that has also been very few and far in between. Because fortunately, in our center, we have been seeing far less number of subglottic stenosis or laryngotracheal stenosis compared to many other centers. I do not know that's a blessing. And that is the reason actually the number of tracheostomies, pediatric tracheostomies is much lower. Adult, we do have, I mean, the stenosis elements, but pediatric stenosis is much rarer. We had to do it in a couple of effective situations, but not much.
Sure. So, Shashi, what has been your indications in the recent 5 years, 10 years, or whatever?
So we do fairly large number of pediatric tracheostomies, and most of the comes from the PICU for prolonged ventilation. And that's neurological kids, syndromic kids, post-transplant kids, when they get stuck, these are the kids which come. As an emergency tracheostomy, we had to do it in RTAs, which is very sad. And the other indication which I can think of is maybe a subglottic hemangioma, because we didn't anticipate that it was a hemangioma. And once you do a tracheostomy and stabilize it, and they later have a look, then you find, because this child was, so you want to do a tracheostomy, depends on the setup where you are. If you do not have the setup to really have a great backup, do it and secure the airway first. That's mandatory. That's a message which I really want to give it to all. My indication for tracheostomy may be much, much later than your indication. But if you do not have a backup where the child can be intubated, or where the child has a good PICU care, it's good to just do a tracheostomy and stabilize the kid rather than actually trying to push it much, much later. And we also had to do one tracheostomy for infective indication as well, and that was bacterial tracheitis, where in spite of cleaning twice bronchoscopically, it would just keep come again and again, and that wouldn't go away.
Right. So what about Amarnath in the recent past? tracheostomies you had to do, pediatric
Yes,
ones?
almost all tracheostomies I have done for the past two to 3 months. There's almost like 10 to 15 I have done, but all are for only ventilative purposes.
Right.
Like only one case I have done only for this post malignancy child who is in sepsis. For this
Right.
again, that was for ventilative purpose.
Right. What about Arpit?
So what I can remember is like apart from the prolonged ventilation, we have done one for the retropharyngeal abscess, and the child was seen in the emergency room.
Right.
And he was struggling for breath, and then and there only we decided to do the tracheostomy in the emergency room only. And actually, child collapsed while we were doing the tracheostomy.
Right.
We were luckily able to revive him, and he did fine later on. Then we eventually treated his retropharyngeal abscess part also. But then by doing the tracheostomy, secured the airway. Recently, doing a endoscopic assessment, we happened to see a bilateral subglottic cyst. So in that situation, it was quite big. And since we were not sure if it's like subglottic hemangioma or not, so we did a tracheostomy, then scanned the child, and on the scan, it was no contrast enhancing. And then it was treated as a subglottic cyst, but the child was tracheostomized in the meantime, so that we should not kind of damage the subglottic area.
Deepak, have the indications for pediatric tracheostomy over a period of time been changing?
So similar to what Sashi was saying, there is more and also so what has happened is over the years, the indication for airway obstruction needing tracheostomy has come down, and majority of times it's all because of ventilation. And also because we are seeing more and more complicated or syndromic kids, neurological kids who need ventilatory support for a long time. Those are the kids who end up getting tracheostomy. We do at least 2 to 3 tracheostomy every week. But those are the indications. Again, some of the things we need to keep in mind is everyone's referral pattern is very different. There are some centers which will have a lot more syndromic kids, and those are coming to their center, and some other centers might not be attracting those kind of kids. It also depends on what kind of NICU and PICU you have. We have a huge NICU. We have like 400-bed NICU. So that by itself will feed, because for the kind of kids they'll be seeing, they'll be having different kind of kids. So yes, there is a difference in pattern. And again, it has become extremely rare that you have to do a tracheostomy emergently. It's extremely rare, but this is something you always need to keep in mind, that it is possible. And you have to, whenever you have a kid who is you might run into trouble, it's better to be prepared and have everything set up. So one of the things is whenever there's a difficult intubation, automatically your tracheostomy set gets opened up, because then you know that if I'm struggling to intubate, if I'm not able to intubate, I'll have to go to that part.
Sure.
So I had to do an emergent trach. Was a kid, twin exit procedure. So twin pregnancy, both of them needed exit procedure. The first one was extremely severe. So to save the second child, we had to immediately deliver the first child, run over, and then did a trach in like 2-3 minutes. And both the kids were fine, but that was probably my only time I had to do a trach emergently.
Right. So what we were trying to emphasize in a country like ours, basically initially many years back, it was mostly infective reasons that the reason for the tracheostomy. And in the recent past, it's becoming more and more airway obstruction. So we compared 2 series, 10-year periods. Somebody else had published their findings, and we compared our findings, and then we found that, which was obvious to anybody who's practicing these days, that is airway obstruction is much more common indication these days than earlier. But having said that, some of the children who have bronchopulmonary dysplasias with low birth weight and come, they get infected, and although they are ventilator dependent, and sometimes you have to do the tracheostomy for them. That is one. Secondly, I think a lot of advancement in non-invasive ventilation has actually brought down the need for tracheostomies from an earlier era. So this is just to tell you that the indications have changed. over a period of time. Things like diphtheria, etc., are not that common these days. And except for a case like Dr. Arpit was mentioning, abscess or something, that's an infective indication, but basically that's to keep the airway safe while you're doing the definitive surgical surgery. Of course, laryngeal papillomas, we don't want to do a tracheostomy, but then sometimes you're pushed into doing that. So these are the various indications that we included.
Dr.
in
Raman,
yeah, go ahead.
Did you actually record the refusal of tracheostomy in this case? Because a lot of the newer trend which we are facing is there's a higher refusal of tracheostomy. If I consent 3, at least 1 would refuse it, and that's in the neonatal group. Have you experienced refusal of, because these sick kids with syndromic, a lot of times the parents don't want to do anything, and they would just say, we are better off, just leave the kid.
I think it depends on the clientele that we serve. I know Gurgaon is a prosperous place, not competing with you guys. But in Bangalore, what happens is most of the parents that we see, they are willing to do what is to be done. But then what happens, there are multiple, what's it called, counseling goes on. And by the time they come with us, I can't remember actually a single child who they refused tracheostomy. So that's been our experience. Anybody else wants to comment on this?
No, not on this exactly, but you were asking me about non-emergency tracheostomy. We had done a planned tracheostomy in one patient to access a lower, tracheal mass in the distal end, because we couldn't access it otherwise. So we had to do a tracheostomy, do a single lung intubation, and then we excised.
I remember you presented it. I think I've seen that. Yes.
Yes, sir.
Yeah. Anybody else? Sorry.
I would just add on, one of the most difficult tracheostomies would be a cystic hygroma, and this kid had an arrest, was not able to intubate, and they were doing CPR, and they asked me to do a tracheostomy. And while they were doing CPR, the neck was dangling like this. And then I was asked to do a track. So finally I could do it and save the kid. But the problem here was a lot of fluid was seeping through the tracheostomy hole. And 4 days, 5 days after the tracheostomy, the child actually died of pulmonary complications, despite having a cuff tube. So I don't know, is it a good idea to do a tracheostomy in a cystic hygroma, large multicystic in the neck? I really want to know the opinion.
No, sometimes you may have to be forced to do it. I remember doing it in one case and I couldn't identify where the trachea was. So what we used was, the fiber of the laser to light up that area, and then localized and then did the tracheostomy. What you're saying is absolutely right. These are difficult cases where you have to do a tracheostomy. Deepak, you want to comment?
For cystic hygroma, majority of these, at least in our experience, what happens is they get picked up prenatally. So most of these kids end up having exit procedure. So when you're doing an exit procedure, you will have an opportunity to intubate in a calm setting. So unlike what Sashi had, my setting would be a little bit more controlled. The main thing I would say when you're intubating a child with cystic hygroma or lymphatic malformation, what you'll see is these cysts are very compressible. So although it might look, when you look into the airway, it looks, but usually your tip of your blade will be able to push the cysts out. The second thing is all these patients from vocal cord below will be normal. So whatever it is, either their cysts, microcysts will be in the supraglottic region or in the tongue base, pushing onto the airway. Once you get that out of the way, once you put your tube in, they'll be fine. So those are patients where you will be able to intubate if you do it in a more calm setting. That's number one. Number two, after that, the tracheostomy itself is a challenge because, again, you need to think your tracheostomy tube is built for a normal neck. And now you have a child with a huge lymphatic malformation. So your tube might not be going all the way into the airway where it should be. So sometimes what you might have to do is you can debulk the lymphatic malformation. When you're doing a trach, just go in and debulk all that lymphatic malformation there before you put, especially if you have already secured endotracheal tube, then you can just go debulk as much as you can, just to give a stable tracheostomy whenever you're doing a tracheostomy. Even then, I would put a flex scope through the tracheostomy tube to make sure it's sitting fine, and you might have to get custom length tracheostomy tube to secure it. So those are a few little tips I would give when you're managing lymphatic malformations.
Absolutely valid. Like Deepak said, one of our exit procedures we had to do for a cystic hygroma, and experts can intubate the child. That's what happened finally. We didn't have to do a tracheostomy, but to anticipate it and plan for it and do it, like he said, in a much relaxed manner. So that's what we did in that particular case where we did the exit procedure.
So a small note, Dr. Raman, is this the case which was I was talking about was in the residency time. Nowadays, we do not do a tracheostomy because there is bleomycin, there is even the excision or really good medical management. So even if you have to keep the child intubated for 2 weeks, you would have a significant reduction in the volume of the masses, most of these lymphovenous masses. So it's good to, even to have the decision, do all you can to avoid a tracheostomy in these kids.
Totally agree with you. Totally agree with you. When you have some other method by which you can do it, it's better.
The other thing you can also do is just stick a needle in emergency. You can just stick a needle in and you can aspirate some of the larger cysts, and that can help reduce some of the things as well. So have that in the back of your mind that you don't have to really do, because just by aspirating some of these big cysts, it might be enough to give you a little bit more stability.
Space, yeah, great. I mean, I think we got a lot of tips on that, and because definitely when you have to do, agreed, you try to avoid it, but you have to do, and you have to take all those precautions in cystic hygroma. Now, if you have to do a pediatric tracheostomy, what are the practical points to be kept in mind? Now, before we go to that, is cricothyrotomy a viable option? Because many times, the general pediatricians also take care of many in India, especially newborns, and they ask this question: can we do a cricothyrotomy? What will be your advice to them? We'll start off with Amarnath. Dr. Amarnath.
A cricothyrotomy, I usually don't advise, number one. Number two, these practical points, like indication for tracheostomy, like if it is for ventilation purpose, I usually plan like doing the third and fourth tracheal rings and all. But if there is tracheostomy for stenosis, like subglottis, I go a little bit lower down. And if it is like some tracheal lesions, like go through the tracheal lesion and all. But cricothyrotomy, I don't think it's a viable option, because I don't think really definitely help the child in future course.
Deepak, as an emergency procedure, cricothyrotomy?
No, I wouldn't do it. The reason is, in an adult, it's a different thing. In a child, as soon as you put your needle through the cricothyroid, what happens is the area above and below gets inflamed. So even when you're doing a tracheostomy, those cartilages almost gets into chondritis and goes away. So when you're doing a cricothyrotomy, you're almost committing this kid to develop subglottic stenosis. If the kid has not had subglottic stenosis, you're committing this kid will end up getting subglottic stenosis. So it is not worth it. You're better off just doing a good tracheostomy.
This question was asked to me by a neonatologist from I think, Himalayan Institute of Medical Sciences somewhere. He says, by the time I get my my ENT or somebody else, is this something that I can keep in mind? That was the context in which he asked. So
the more likely it cause damage.
I mean, what Dr. Deepak said is absolutely right. But the Nelson book and other book mention a procedure in which they would actually puncture it and put a large bore flexible cannula through the cricothyroid membrane and ventilate the kid till the definitive surgery is done. If they're not able to ventilate it, but absolutely no for a cricothyrotomy where you're putting the tube through that. You can just put a cannula to have some ventilation just to buy some time.
Yeah, this was the question that he was asking me. So,
for buying time, yes. Like what Sashi said, that's fine. If you're just putting a little cannula and you're buying time, again,
exactly.
those situations should be extremely rare.
Yeah. So this was the question that neonatologist asked me. So in case he's got nothing else and he has to do it as an emergency procedure, you people would agree that you can put a small cannula for a short time so that you buy time before a definitive procedure is done.
Probably the best thing to buy time would be a Thrive, or you can put a nasal number 8 or number 10 feeding tube and give 6 to 10 liters of oxygen and put the feeding tube at the level of larynx, rather than, doing an unshort procedure where you are actually injuring the vocal cord or down and causing a further edema. So I would just say using a Thrive machine or a, nasal feeding tube is a good way to buy time. If you're
you are in a good, nice corporate hospital. Thrive and all these people do not have in those places.
Feeding tube. Feeding tube.
I agree with you. So basically, it should be discouraged. But if it's something that's going to keep the child alive, you have no other option. As a temporary measure, can we say you could attempt it?
I would say yes.
I was just trying to get an answer to put it in the right way. Yeah, go ahead.
And I would say just to save a life, anything to save a life.
True.
All the other things have failed.
True. Thanks. So we go to pediatric tracheostomy, the practical points. Just shoot the next slide. So we've just given the whole scenario. Like I said, this particular session is addressed to general ENT surgeons, and then many of us may not have had the experience of doing tracheostomy in children. So I want you to comment on these things, anything special which is important, anything different that you do. Let's start with Arpit, anything you want to say? You can have a look at the slide. And
so if I'm doing a very young child, I will take I'll follow, usually we'll do a tracheostomy at the level 2nd, 3rd ring, and we'll take a vertical incision. If I'm taking a vertical incision, I'll take the stay stitches. I will secure that also in the neck. And after doing the tracheostomy, I will secure the tube also with the stitches. And if at all, if I'm doing a slightly older child, I will do a jock flap only, and will try to mature the stoma all around. Because if the child is going to be on a tracheostomy for long, it is very easy to kind of change the tubes in the later period. It is easier for the parents also to kind of change the tube in the later, whenever the child is coming with the change of tubes also. So these are the 2 things that I will keep in mind.
Yeah, Dr. Amarnath.
So first, procedure is same, but the only thing is I never do a vertical incision. I always do horizontal incision on the trachea. And another thing is, like, usually I remove the subcutaneous fat at the time of the incision, just to make sure that even if the Zork flap is not well adjusted, and that thick of tissue, subcutaneous fat will give some sort of faster maturation.
Right. Shashi?
So we started with vertical, now moved on to horizontal. If it's an emergency, you don't have much of time, use vertical. But if you have a nice time to do a tracheostomy, take a horizontal incision, remove as much fat as you can. And the big debate about using jock flap versus just a vertical incision continues. And there are, publications to support both of them. I did not find particularly a big advantage in using the flap and the additional time it takes. But if you are able to take skin bites near the tracheostomy opening, where the trachea is open, so you are actually committing that there won't be any false track, and in case of accidental decannulation, you are saving the child. So irrespective you are taking jog flap or not, try to have the lower end of the skin suture to the tracheostomy opening. That's a fundamental thing. Again, the side 2, 3, 4, the lower the better it is. it's very easy to injure the pleura of the lung in the youngest of the infants. So you have to be very mindful. The thing which you are holding with the retractor may actually have an inflating lung below it. And if you're not careful and you're using a cat's paw, you may actually rupture the lung. That's the fundamental thing. And lastly, the tube size. Now, the problem with, there are only 3 tubes available in India. One is the Rush, the Portex, and the Bivona, which is a silicone. In terms of inserting, the Rush tube has the highest difficulty. Bivona goes easiest because of the stillet. Portex, the problem is the tube, when it's put it in the package, the flanges are bent backwards. And when you try to the skin, the flange and the tube, they're not properly aligned. So you have to ask someone to actually rebend the flanges so that they're in the proper alignment. But if you're using a tube, just be mindful that the length of the tube is also as important as the diameter of the tube. And if you have a longer length tube, when you need a longer length tube, you need to place your tracheostomy incision according to the size you require. So we always keep only the diameter in the mind, but the length of the tube is also very important where you want to place it. If it's a tracheomalacia and you want your tracheostomy tube opening as close to the carina, you might want to do a tracheostomy a little lower down so that even with a normal diameter, you're able to reach that part.
Wonderful. Thanks for those points. Deepak, you want to say something?
So whenever you do a pediatric, again, the debate about vertical or horizontal doesn't matter, because at the end, it'll all become round. However you do, it'll be a round hole. So it doesn't matter. You do whatever you're comfortable with. The second part is always take the fat out, because that will come in the way. So it's better to just clean that up by taking the fat out. This is a good picture showing your retractors and the trachea in the middle. It's very important to palpate. No matter how many times you palpate, it's always, you need to reassure yourself that you're putting the trach at the right spot. So you should always palpate, because in little kids, it can be very difficult to say what is exactly cricoid, what is thyroid. And also the other important structure you need to palpate for is the innominate. So you'll be surprised how close the innominate can be at the lower part, especially if you, the tendency is to put a big shoulder roll. The shoulder roll, when you hyperextend, the innominate will come up in little babies. So don't put a huge shoulder roll, put a appropriate size shoulder roll, and always palpate, multiple times palpate to make sure you're at the right spot. And then when you make the incision, there is no evidence of Bjork flap in pediatric tracheostomy. So all that evidence is on the adult side. I don't care what you do on your adult side. On kids, you shouldn't be doing any flaps, because one, it can be dangerous if the flap comes out, it can obstruct the airway. Two, you're putting the child to end up getting tracheal stenosis. There is already only so much trachea and you're taking the part of the trachea out. So I don't think we should do Bjork flaps on pediatric tracheostomies. The next thing is maturing, like what Sashi was saying, maturing the stoma, where you put stitch through the skin, go to the edge of the trachea and come out to the skin. That prevents false passaging. If the trach comes out by mistake, it won't go into wrong passage, because the trachea is literally sitting on the skin. So it's easy to put it back in. And having stay sutures on either side will help. And then when you're putting the trach in, one of the important things is to communicate with your anesthesiologist. Because what happens is, when they're retracting the tube, you don't want the tube to be completely come out. You want the tube to be sitting right above your upper end of your tracheostomy, so that you can still ventilate while you put your tracheostomy tube in. Once you put your tracheostomy tube in, you change your circuit, you confirm that you're getting ventilation. Once you're happy with the ventilation, then they can take the tube out. But until then, sometimes say you have false passage the tracheostomy tube. That's when you'll panic. And if the tube is out, it might be a difficult intubation, and then you're making yourself. So it'll be easy if the tube, they can just slide it further in and they can still ventilate. So it's important to have the tip of the tube right above your tracheostoma before you put your trach in, make sure you're okay. And after you secure everything, I would take the shoulder roll off, put a flex scope through the tracheostomy to see where it is sitting. Is it sitting above carina, where it's sitting, what's happening? It's important to get that information before you drop the kid off to the ICU, because you don't want them to have trouble and then you say like, oh, maybe this is happening, maybe that is happening. When you're dropping off this kid to ICU, you know exactly where the tube is sitting, what is happening to the lower airway, all that. So these will be my important steps when you're doing a tracheostomy.
Wonderful, great summary of the whole thing. And yes, the trachea seems to sometimes wanders around, and it's always touch, feel, make sure that you're on the trachea. In fact, the second picture, the incision picture on the screen, it's basically me holding the trachea there when a person is being trained in pediatric tracheostomies to make sure it's there and that they feel it. So I just hold and tell them it's very important that it's right at the place where it should be, because it tends to go to the left, right, and then sometimes you are left searching for the trachea. So all these very valid points, actually. So we'll go to the next slide.
One point,
yeah, go ahead.
We emphasize not to use too much extension.
Right.
Yeah, because what happens, the level of the skin entry and the tracheal entry becomes different. And while inserting the tube, the shaft of the tube impinges on the upper trachea and kind of creates stenosis over there.
Right.
Yeah, I agree with that. Sir, for a beginner, sorry, sir. For a person who is not doing pediatric tracheostomies regularly, it's actually extremely important that there's no rotation of the head while doing the tracheostomy. And as Arpit said, traction, as you showed, you holding the trachea, the traction of the assistant is very important. Equal traction on both sides. A little fraction of a more traction on one side is going to pull the trachea really off center, and it might be an issue. And the third point I'd like to make is the length of the tracheostomy tubes. Sometimes during extension, it doesn't hit the carina, but later on when the child is flexing, it can go and hit on the carina and cause a lot of irritation.
True. All points taken. I think we got an excellent set of points. Yeah, go ahead, please.
A very common problem which happens is you're done the tracheostomy, and before the tracheostomy, the child was ventilating well. But as soon as you're done the tracheostomy ventilation is very poor. There's a lot of air leak, and the anesthetist is saying that the tidal volume is not enough delivered. And that's when the whole story starts, that you are doubtful that have you put the tracheostomy in the right place, because there's some untidal CO2 there. So the whole problem is with the curvature of the tube. So when I said there are 3 tubes, one is the Rush, the other is the Bivona tube has the best curvature along with the tracheostomy angulation. The ones which are really angulated, almost some of them would look like a 90-degree. They would go and actually hit on the posterior wall of the trachea or on the anterior wall of the trachea. So once you finish the tracheostomy, you need to check it with a flexible scope, that where exactly is your tube, at how much distance from the carina, and what is the angulation it is approaching this. Because you might want to keep a gauze here or there and change the angulation to improve your ventilation, because it's a very, very common problem. You've done a good tracheostomy, but the ventilation is just not happening good enough.
Totally agree with Shashi.
Great point.
The most common problem,
invariably you get a call from there, and after finishing you have to go run there and sort it out. Yeah, very true. Any other comments from anybody else? I think we got the fairly, okay, let's go to the next one. Next slide. This is just to give an idea to our general ENT practitioners. What are the common pathologies? I know you're all airway surgeons, and you have probably selected the cases coming to you because of your reputation and your referral pattern. But even then, it'll give us some idea what are the pathologies that you see. Let's go to the next slide and see whether your experience is the same as, we've gone into spectrum of laryngeal lesions. Okay, fine. So there's a whole lot of, things that you can face in the larynx. And of course, this is already discussed: inspiratory stridor, biphasic stridor, expiratory stridor. And we've divided all the causes like laryngomalacia, laryngoceal stenosis, vascular malformations, supraglottic pathology, glottic vocal cord paralysis, intubation injury, laryngeal cleft, glottic web, stenosis, laryngeal trauma and fracture, subglottis group, intubation granulation edema, acquired stenosis, hemangioma, cysts. This is more a theoretical list which you need to be aware of. I think we've already discussed some of these, so we'll just go to the next slide and see what in your practice is the commonest. So this is the international, of course, figures. So we'll start with Shashi. Shashi, what do you see most?
I think we see all of these, and laryngomalacia is most common. And nowadays we operate more in laryngomalacia than any other lesion.
Right.
Other than that, yeah, that's what the most we see. A lot of neuromuscular dystrophies actually, which is presenting as respiratory distress, but we don't actually know where exactly is the cause. Laryngomalacia, tracheomalacia. So my point to the residents was always like, there is often only one cockroach in the kitchen. So if you have one laryngomalacia, you have to look for other anomalies as well. So that's where the whole story starts off for the airway workup. So there are always other cockroaches roaming around. You need to pick them up. Reflux, airway allergies and everything.
Right. Gautam?
So we see the majority is laryngomalacia, like everyone else, and laryngeal webs, yes. Laryngeal clefts, we have seen a few, and subglottic hemangioma. I have not had non-canalization of larynx. Subglottic stenosis, very less actually. And
Right.
vocal cord dysfunction also in pediatric, my experience is less.
And what about Amarnath, Dr. Amarnath? Is Dr. Amarnath around? Okay, we'll go to Arpit has answered. No, Arpit?
We have seen all of them, but most common is the laryngomalacia. Apart from that, the post-intubation stenosis or failure to extubate sometimes. That if the patient is already in the ICU, that's the most often situation that we see.
Right. That's how they come to you. Yeah, you're right. Absolutely. So Deepak, you must be having a plethora of conditions.
No, it's very similar. Nothing different. The only difference in my practice is not for stridor, but as such, I have a bigger practice of laryngeal clefts because a lot of kids who are aspirating come to me, and I manage a lot of kids with aspiration. So I have a bigger series of laryngeal clefts compared to rest of the thing. But otherwise, yes, laryngomalacia is the commonest thing and similar to the numbers you showed.
So we have a number of airway problems, as you must have seen. Starting off, airway includes the nose, of course, and the choanal-atresia, nasopharyngeal masses. Then we've had the sublingual mucocele, macroglossia can cause problems, vallicular cysts, and various types of cysts in different situations. Laryngomalacia, of course, bifid epiglottis is part of the syndromic thing. Laryngeal hamartomas. Yeah, next slide. Non-canalization, laryngeal webs, vocal cord palsy. I think vocal cord palsy also depends on how active your cardiothoracic department is, because many times they are referred from there. Am I right, Deepak, as far as vocal cord palsies are concerned?
Correct. It again, even like places like ours, the cardiothoracic surgeons believe that they don't damage any recurrent laryngeal nerve.
Very true.
So you need to convince them that it is important. So the two things you need to see is a lot of these kids might not have obvious voice issues, or because they're little, they might present more with swallowing issues. So they might show signs of aspiration. So it's more you look out for them. There is up to like 25% of cardiac patients end up having some kind of vocal cord paresis. So it's important to keep an eye on them. Majority of them will get better. But again, some of them might not get better, and you might have to do something about it. So it's a group where you need to keep an eye on.
So one of our large cardiac centers had a case where the uncle, the kid was from Pakistan. So the uncle was an ENT surgeon. So he insisted that the child be seen by an ENT. So they sent the child all the way across to us. And then, see, that began our friendship with Pakistani ENT surgeons, and we got a couple of patients from them. But initially, the reluctance to say that anything can happen post-cardiac surgery is very much there. And the number is there, like Deepak said, many of them just much of intervention. And importantly, he also said about the swallowing problems that they have at that particular time. It's not identified or not attended to. So we need to keep that in mind. So that's it. The reflex, of course, hemangioma, thanks to propranolol, it's great. And subglottic stenosis, we've talked, Deepak has talked about that. Tracheomalacia, and then tracheal problems are also there, complete tracheal rings, and then stenosis at the level of the bifurcation, as you can see here. So here we have, yeah, go to the next one, that's fine. Yeah. Next, yeah. So do you have any criteria for when to intervene for and what are the indications for supraglottoplasty, so to say? Yeah, that's the composite term, umbrella term for whatever you do to the larynx at that level. I think for the sake of time, what we will do is we'll put up the slide and have the discussion rather than, conduct an exam, viva exam for our experts. So yeah, this is, I think, Robin Cotton's initial curlers and floppers. So this is an easy way to sometimes explain to the younger doctors as to what happens. And we've got other types of classifications also. You can go to the next slide. Yeah. So these are the indications that have been listed, usually absolute indications, relative indications. So what are the things that you think is different in your point of view or in your practice regarding the indication for laryngomalacia? Do you observe some children? Some children you say, okay, it's fine. Observe the child for 2 months or 3 months, you come back to us. Do you do that? Or you just, anybody who's having laryngomalacia and has stridor, you immediately do a flex bronch, confirm it, and then take the child up to the theater? What do you do? We'll start with Gautam. Do we have Gautam there?
So yeah.
Yeah.
So it's the major indication would be failure to thrive.
Right. So by and large, you kind of adhere to what's listed here. Is that what you're saying?
Yes.
Okay. So what about Arpit?
Yeah, majority of like the failure to thrive, too much of a stridor where the saturation is like in the 80s, and the child is having struggling for breath, and too much of retractions are also there.
Right.
And apart from that, feeding difficulties are also there because that the child is not able to gain weight.
That really frustrates the mother, the feeding difficulties, apart from the respiratory issues. We've seen, I don't know, in your experience, and they come back and say, please do something. And so that's something that's very distressing for the parents from my little experience. And what about Amarnath? Do you agree with this by and large?
Yes, sir. We are doing, but more or less similar experience only. But we do only patients children who are not improving or who are going for failure to thrive and breathing more and more desaturation.
So you have some kind of a selection process, am I right?
Yeah, yes, sir.
So does it include some, when you see the child initially and you say that I want to see the child again after 2 months or 3 months, do you do that?
Yeah, I will do, sir. I'm doing same. I'm doing what is this? Again, flexible endoscopy and then confirming the situation.
Okay. Did I ask Shashi as yet? Yeah.
So this is one of the hardest question you can put ever to a panel, Dr. Raman. Why? Because why would you want a child to suffer to go to absolute core pulmonary hypertension or failure to thrive when the treatment is simple, just slip off the excessive mucosa?
No. This is when a child comes with carpal for you.
Yeah.
It's not you're waiting for carpal to happen. It's before that.
So when you get to operate is more dependent on how good your relationship with the pediatrician is. If your results have been really good, you get an early referral. Otherwise, the pediatrician is going to say, wait for 3 months, wait for 6 months, wait for 9 months, and the child is in a literally a big mess. And then, as a last resort, they're just coming to you for a surgery. So it is our duty to educate our pediatrician colleague that, hey, this is what it is. 95% below SATs, feeding problem, no weight gain in 6 weeks. You have to give this child to us. And that's a clear line we draw with our pediatricians. And they're very happy to send it because one small supraglottoplasty, and it's like one of the most beautiful, miraculous surgeries which anyone can do in a child.
Absolutely.
You don't need a great training to do it. Just a scissors, no big instrumentation. But at the same time, the first assessment, when I say we do it flex and repeat with flex, you give them the red flags. These are the red flags. And parents, once they see the video, they want to come in 2 weeks interval rather than 2 months or 6 months interval. So in 6 weeks, they're not gaining enough weight. I would generally not push a child to such a big misery when the answer is simple.
Absolutely.
Dr. Raman.
So basically, you need to be in touch with the pediatricians, make them understand. Luckily, we have a band of pediatricians who are totally involved in our center. So we are lucky from that point of view. They almost send any child having. Sorry, go ahead.
Doing a OPD examination with a flexible also helps. You are immediately able to see what exactly the situation.
Sure,
If it is not going to be requiring too much of a intervention, simple cut, trimming the folds with a cold steel. If that is going to improve, you can accordingly counsel and do the intervention earliest also.
No, basically we were saying what is it that tips the balance towards from conservative to surgery is what we wanted to have a better understanding. Deepak, what do you do in your place?
Majority of these, almost all of these patients come to the outpatient. I have a speech pathologist with me when we assess these patients. Both of us assess the patient together. A lot of these patients, as you rightly said, have feeding difficulties. And a lot of those things can be managed by the speech pathologist. They can give them different tips to help them manage both the feeding issues, but also seeing that they start to gain weight. Because one of the main things, as we discussed earlier, is failure to thrive is the main indication. So if we can get away with doing things which can help the child, if they have reflux, treating the reflux, if they can thicken the feeds or do other interventions with feeding, and I always see them in 4 to 6 weeks time. If I'm really, really worried about them, then I see them sooner. Otherwise, I'll see them in 4 to 6 weeks time. At that point, I'll decide if this kid is not getting better, still having failure to thrive. It's very easy to convince the family that this is what is needed because they are struggling as well. But the indications are very similar. So I ask them to look for a weight gain is most important. Blue episodes is a red flag for me to take them to the OR sooner. If they are having apneic episodes, that's again a point where we take. And then the other things, it's extremely rare for you to get to corpus now. Nowadays, you shouldn't get any child going into corpus lab. With the pediatricians we have, with the understanding we have, and group of surgeons who can take care of them, you shouldn't even get to that point. So, and yes, if it is done properly, a supraglottoplasty is a very good surgery. Well, I'll just add one more thing. Based on supraglottoplasty, someone compared supraglottoplasty to tonsillectomy. So we do tonsillectomies on sleep disordered breathing, where we just go with the history and go ahead and take their tonsils out, correct? And it is 95% successful. Supraglottoplasty is also 95% successful. So why are we not doing more of supraglottoplasty? But saying that, I'm not advocating that we should be doing more and more, but it is a good surgery in good hands. It's mainly understanding what needs to be done in these patients, and you can have good results with it, but do it for the right reasons. Even with all these, about 80% of them you can manage conservatively. You'll still have about 20 to 30% you'll have to do surgical intervention. But once you take them to the OR, there's no point waking them up. If I'm taking them to the OR, putting them through anesthesia for full assessment, I might as well fix the laryngomalacia. Then I'm not waking them up, sending them home, bringing them back. I'll just take care of it then and there.
Right. I think important points. I also, like Deepak, like to see the child more than once, maybe 4 to 6 weeks later and stuff like that. But we have excellent understanding with our pediatricians, and we discuss with the parents and the pediatricians, and then come to decide. We've also come out with some kind of a staging system, which was presented by Deepa and Semtac, I think, in the recent past. So we're trying to see how to make it as objective as possible and not very subjective in terms of when to intervene, etc., etc. All points well taken. So the next next slide, yeah. So yeah, here we come. Are you going to use cold cut? Are you going to use laser? Are you going to use coablation? So we go from A is Amarnath. Amarnath, your choice.
Sorry, I usually do cold, and nowadays I'm using coablation also, but
Okay.
I've never used laser at all.
Okay. Now next is Gautam.
Mainly cold instruments and coablation.
Wonderful. And Shashi?
Cold instruments, and I'm actually against using coablator because the collateral damage is too much in those naive larynxes. The only exception where I would use a coablator is there's a hemostasis issue and you want to bipolar the mucosa, which is rarely required, but a cold instrumentation or a micro debrider sometimes, skimmer blade will do the job. Coablator, sadly big no from my side.
Arpit?
Preferably cold steel only, sparingly coablation, because I agree with Shashi, with such a small larynx, sometimes the coablator is too big and you end up kind of damaging and doing the collateral damage. So the best thing is to cold steel.
Even with an MLW?
Yeah, but MLW again is difficult to maneuver in that area. It's such a such a small child, MLW is such a long wand to just precisely use it's difficult.
Right, right. So, I mean, choice of instrument is left with the surgeon, whatever you're comfortable with, and make sure that you don't cause any damage. Laryngomalacia, I think we should have zero damage actually. So we must make sure. Does the video on the left side work? If you can do that, we did just for the sake of, we did on one side, we did cold steel and the other side, we used a fiber laser luminous and we found no difference. So it doesn't really make any difference. Any heat instrument has to be used with extreme caution. And if it is a debrider, again, it's a powered instrument, so you must be very precise and be very careful about that. And let's get to know what Deepak says. I'm sure he says cold steel can do anything that any of the other instruments can do. Am I right, Deepak?
Yeah, I would do cold steel. Why add on expense to the family when it gives you equally or even better results? The cold steel will give you better results than any other.
So on the left side, sorry to interrupt you, Deepak. Left side, you see almost the same result with cold steel and the laser. So it doesn't really make a difference if you know how to do
the other thing is you've been very careful. The problem is when people start to use and not being careful, more likely will cause damage when you're using a coablator or a laser. I would, in infants, it's in a teenager with sleep apnea or a neurological kid who is 5 years old and has sleep apnea and has laryngomalacia, sleep-induced laryngomalacia. That's a different group of kids. But in an infant, I think cold steel should be the standard of care.
Absolutely. So the simpler, the non-damaging one where you can't create any damage, and the tendency to overdo things because it looks very good immediately and create problems for a larynx. I think you should have literally zero complications. And somebody is advised one side Refusal and not both sides. I think if you know how to do it, you can manage these things with simple cold cut. It's like staphylectomy in autosclerosis. I mean, absolutely wonderful results, and we need to choose our patient, use the right tool for that. Next slide.
Dr. Raman, what about the intubation? Do you think intubation should be done when you're doing a supraglottoplasty or the way you're doing it? Because the anesthetist will not give a case like that. You're lucky to have it.
I'm very privileged. I have an excellent team. I mean, it's all of you know about it. So even doing a cleft without a tracheostomy, and I'm not a quick surgeon as far as cleft is concerned. I don't have the experience that other people have. I take a lot of time, but I have it without the tube. So we are lucky. I think that should be our aim. If we can have the whole field to us, I think the damage is much less. Next one. Yeah. Yeah, vocal fold mobility. How easy is it, to suspect vocal fold mobility when you do a flexible scope, and then how do you arrive at the diagnosis? You want to say something, Deepak?
I saw a smile on Sashi's face. No, so it can be easy, at the same time it can be very difficult.
Yeah.
So it needs to go in with, are you looking at it? You need to look at it with watching the child's respiration, especially if your assisted ventilation is happening, if someone is giving some assisted ventilation, then you might get a false movement. So like this you're seeing, this is probably from assisted ventilation because you're blowing some air. So it just gives you a false sense that the cords are moving, but the cords are really not moving. So assessing that, see, unilateral is a lot more easier because you'll see one side moving, other side is not moving. But there are times where it becomes very difficult, especially if there is an overhanging of the epiglottis, you can't see the vocal cords well. That is where the ultrasound might be more helpful. So using the ultrasound to look for that mobility can be helpful. But again, it's a subjective thing. Someone needs to be a little bit more experienced at doing ultrasound to be able to pick that up, but that's possible. But those will be the main things. Do it in line with your respiratory pattern so that you're seeing what's happening when you're
right. Good advice. So it's not that easy. So one need to take into account what all Deepak has said. And in fact, one of the publications, I don't remember, but it said that it's not as simple as one makes it out to be. And one of the things that is important is to record the whole thing and then view it, if necessary, in slow motion or whatever it is. And it's very important that which phase of respiration, the movements you're seeing or not seeing, based on that. And of course, history and all those things are also important. And yeah, unilateral or bilateral, sometimes they don't present at birth. Usually they have a weak cry, speech therapy, thyroplasty, etc. So one wouldn't talk about thyroplasty at this stage, would you? Shashi?
Thyroplasty, I haven't done any thyroplasties for less than 12 years. I don't know.
Right.
There's no literature pro or against it, but it's something where the literature is deficient. I would just say.
See, it is a growing larynx. So there is no point doing a thyroplasty because the larynx will keep growing. What will your implant do? There is a paper, Dana Thompson wrote a paper many years back. She had a series of 2. I have done 2 thyroplasties in teenagers. But again, the thing is, it is a growing larynx. So why would you do it when you have other ways to help you? Especially, we can do a more definitive procedure later.
Right. So what would you be for bilateral vocal cord palsy with the child is having stridor? What would be the choice of procedures? I know each one has its advantages and disadvantages.
So we did a series of 23 patients with suture lateralization.
Yeah.
And a lot of them failed because we were not taking cordotomy cuts.
Right.
So if you don't have any instrumentation, you don't have coblator or anything, just cold instrumentation, then suture lateralization with a posterior cordotomy works extremely well.
Right.
If you are doing a ablative procedure and you don't have a laser, I think coblator is a great tool here because it gives you a good volume reduction and exposes the arytenoids process very nicely, and also gives you a good hemostasis. And I'm not a big fan of Kashima procedure per se, because it's a 3-dimensional surgery and a lot of people don't understand Kashima procedure. So I don't say it's a very good, we had to do a lot of revision cases of Kashima done by other people in children. And posterior grafting is something which I would do if I'm doing for other indication like a posterior glottic stenosis with a bilateral vocal cord palsy. But to do it as a primary, I've just done for 2 cases. So because the need for tracheostomy and I don't do a Inglis procedure, so I would rather just do a ablative procedure rather than convince a patient to have a tract and do a posterior glottic implantation.
Likewise, I think any destructive procedure, if possible, should be avoided. Wait and watch. Some children improve over a period of time if they're not too bad. Then recently in the last 2 years or so, I think we've done for cordotomy for 2 patients, and that's what they're doing well without too much of problem with the voice. But these are all difficult decisions to take. Anybody else wants to comment on these cases? Sarpit, you want to say something?
Yeah, so posterior cricoid split is again difficult to convince the patient because it will involve a tracheostomy if the patient is not having one. And putting a mold to secure that, again, they don't want it. And I think Kashima has worked well for me. As rightly said by Shashi, it's a 3-dimensional, you need to do it, basically. So I have like only 4 cases that we have done it, and it has worked well for me.
Right, great. Anybody else wants to add? Or shall we go to the next slide? I think we're out of time.
Dr. Raman, I'll just add few things. Or Gautam wanted to say something.
Yeah, sure.
I just wanted to say that I do not have experience in children with bilateral palsy, but Kashima operation is a destructive surgery. So I look at it with some amount of caution, because you're not going to, you are unable to reverse this surgery at any point of time. Even if you think about re-innervation surgeries or whatever, if something new comes up, that child, when he grows to be 20, maybe something new comes up, but you have done a Kashima, it cannot be undone.
So, what about, do you have to resort to tracheostomy in some other cases? Tracheostomy versus cordectomy, which one would you prefer?
No, I would say suture lateralization would be better.
Suture lateralization?
Yes, sir.
Okay.
Sir, can I ask Dr. Deepak, what is his experience with suture lateralization, and are they able to reverse it when later on the child has got the bilateral nerves working?
So in my experience, if an infant with bilateral vocal cord palsy needs an airway intervention, I would go with endoscopic anterior posterior cricoid split. So I showed you in my talk, we cut the anterior cricoid, then cut the posterior cricoid, then use a balloon to stretch it open, and then keep them intubated for a week, and then we take it out. It works in about 60 to 70% of patients. That way you can avoid tracheostomy. I personally haven't done any vocal cord lateralization. To me, it is extremely difficult in infants. In older kids, it might be easier, but in infants, to get that suture right at the vocal process and to be able to lateralize it, it's a challenge because the suture tends to slip. So you're not getting that, you do the whole procedure and if you're not satisfied at the end of it, then what's the point? So that is my personal, and maybe I'm not that good of a surgeon that I can lateralize well. And there might be something wrong with the way I was trying to do it, but I didn't get good results with it. So I don't do lateralization. The second group of kids they already have a trach, and what do you do to get the trach out? Those kids, I usually put a posterior graft. And for putting a posterior graft, you need not have a trach. You can do it as a single stage procedure as well, even if they didn't have a trach, but I don't do posterior graft on infants. In infants, posterior graft will be extremely difficult, but say the kid is 18 months old, 2 years old, when you know that the nerve is not going to recover, those group of kids, you can do posterior graft, or you can discuss about ablative procedure, where is cordotomy or things like that. Recently, or last year and a half, we have done 2 kids. We have done bilateral phrenic nerve reinnervation. And so far, we have had good results with that. So these are older kids where we have done phrenic nerve reinnervation bilaterally, and it seems to work in these patients. So that might be, there is more and more coming out. Marshall Smith from Utah has done few cases, and I forget the name of the French guy who actually started doing them. He's done more on the adult side, but there is literature coming out on the pediatric side as well. that it works well. But it's a big, tedious operation. It takes almost all day to do it. And we don't have long-term results and what happens, but so far the results have been very encouraging.
Right. Next slide. Thanks for those comments. Next slide. Need to go to one important point before we conclude. I think we are close to Gautam. We have some time. Few minutes.
We have actually supposed to end at 3.
I'll just sum it up.
End at 8:30 maybe. Vijay is here. Vijay can tell us. 8:30.
Fine, sir. Fine, sir. We can go ahead with a couple of questions.
Just 5 minutes. Now we've, I think Deepak has covered this subglottic stenosis, endoscopic versus open, and how to select the right size for the balloons. All practical things. Maybe quickly somebody can summarize this.
I think the best way to is download the app called Airway app from Cincinnati Children's.
Yeah,
it gives you the balloon and everything.
Yeah, and keep it with you and on your phone. So that's what we do. So it's simple, but please do what is advocated and don't try any new stunts. And this, of course, next slide.
I'll just add one more thing while we are moving slides, Dr. Raman.
Sure, please.
A lot of times what happens is people use, say, Fogarty balloon and thinking that all balloons are same. They're not the same. Even pulmonary esophageal balloons are not the same. So one of the things to keep in mind is what is the burst pressure of the balloon. So if your burst pressure is very low, then it's not going to do its job. So having the right size balloon and having the right pressure on the balloon is very important. So using the right balloon, which creates a lot of coronary balloons like the cardiac balloons probably will be equivalent if you don't have the actual airway balloon, but keep that in mind, both the size and the atmospheres, how much atmosphere you are going to use. And then seeing the end result. When you do the balloon dilation, you should see that everything is opened up. If it is not opened up, either the scar is too thick, then you might have to use something else to open things up, and then you can repeat the balloon dilation. But keep that in mind. It's very easy to say, I tried this, but it didn't work. Obviously, it didn't work because there was not enough pressure gone in.
It's actually, sorry, go ahead.
I think adding steroid as an infiltration or local application also works wonders. Can be done, should be done, I think.
Sure. So actually we included this basically because I'm using a derogatory term, part-time airway surgeons, I call them. They just take whatever is available, dilate it and leave it. And all kinds of things have been used. It looks very good initially, and later it causes a lot of problems. We'll go to that part later. Next slide. So we wanted the basic outline of anybody who's using a balloon. Please try to understand which balloon to use, how to use, right size. Adding steroid, as Arpit has said, is important, and keep the children under follow-up. Airway lesion, yeah. So next slide. Next slide. Yeah, what's the next? Yeah, right. Webs, so right, we leave that. Posterior laryngeal cleft, you leave that. I think they need to go into depth for all these things. The next one, I think we should conclude talking about, the choice of instruments is very, very important. Yeah, one diagnosis which is missed definitely is the laryngeal cleft, missed by us, sometimes missed by pediatricians. We don't get the referral because that's not suspected, so you need to suspect it. And then important thing is the inspection and palpation that has to be done, and then exclude a cleft. Then there are sometimes, the next slide, please. Can you see the next slide? We are short of time before the lights are switched off by Vijay Krishnan, so we need to be careful. Yeah, okay, this I think is okay. Next one. Injection laryngoplasty in, for clefts, type 1 clefts. I remember many years back, Deepak talking about it, and he was telling us how it is important, even if you want to operate on the child, to initially inject, and then the parents feel good, then you go in, especially in type 1 cleft. Am I right, Deepak? Am I quoting you properly?
Yes, these are kids where you're not sure when you're going in. These are not older kids. These are infants where you're not sure. It looks very deep. You can inject, and then it gives you a fair idea of what's going on. And then the parents feel better about it that, yeah, the kid was choking, and then it's easier. And the surprising thing is about half these kids got better, that you didn't have to do a formal repair. And this is, again, we are talking about infants, less than 1 year age, where you inject and then they get better. So, and if the ones who get better and then the symptoms come back, it's easier for you to convince yourself and the parents to go ahead and do a formal repair.
Yeah. And then we also have the confounder, the deep interarytenoid notch DINs. So it'll all be based on the symptoms, and then you decided to intervene or not. I think we won't go into that. That's for an airway conference. Next slide. Yeah, okay. So the previous slide was a child at age 7, I think, with a very deep cleft, and she didn't have any symptoms. And the parents, she was, weight was less for her age, and she had noisy breathing. They didn't want anything to be done. So advancement instrumentation, I think we've talked about balloon, microdebrider, coagulation, microlaryngeal wand. I think we passed this. Because one important message in this particular forum we want to talk about, I'm sure Deepak is also very keen on talking about it, is next one. Do we have the slide with the... Okay, let me tell you about this unfortunate child. We won't name names, we won't say anything, but this is becoming a big problem these days. We are seeing a number of cases where inappropriate instrumentation is used, and we get a larynx which is baked, cooked, and sometimes there's no larynx at all. And the new breed of people who have started doing this, apart from us as ENT surgeons who want to use laser, we want to use coablation, we don't know how to use it, or we are very aggressive about that, and we damage the entire larynx. This particular case was, you'll be surprised, had a cyst probably in the vallicula. Child had multiple upper respiratory infections, and subsequently sent to the ENT, and the interventional pediatric pulmonologist had a go at the child, went and used a laser, and at one time when things didn't work, they went and used a diathermy. And then they, in a small 3-year-old child, they used a size 10 T-tube and nothing worked. All kinds of things which are not at all rational were done, and the entire larynx was damaged. And it's such a struggle to go and set right a supraglottic stenosis in these children where tissues are damaged. And next one. Next slide, please. So I think we need to address this and spread the message that the pediatric, look at the complete supraglottic complete adhesions. The whole thing is damaged. So I think we should spread the news around that, the pediatric larynx is very sacred. And especially people who are in our sister specialties like pediatric pulmonology, invasive pulmonology is fine, but they should know their limitations. I don't know whether any one of you have seen this kind of really totally damaged larynxes, sometimes by us, our fraternity, and sometimes by the others. You want to say something, Deepak, on this?
I would.
Shashi? Yeah, please, Shashi, please.
So, one case, 27 laser surgery for a kid who had a laryngeal web from the birth to 22 years of age. Was done at a premier institute. We had to do another 25 surgeries. At the 52nd surgery, the child was finally decannulated. I'm facing a brunt, another female who had 67 surgeries, finally decannulated. So transglottic stenosis, the one which you are saying, is the biggest curse. And if you're not able to get it right in 2 or 3 and you're not making a progress, it's better to refer these to some centers which are doing the airway surgeries, then trying to solve the problem again and again on your own. I would say this is a very important point which you have raised.
I knew that ENT surgeons were guilty, but the new breed has also started. So I thought I should talk about this because a new idea for the pediatric pulmonologists. So they've started doing this, what they call as intervention and not open surgery, and it appeals to the parents, and ultimately they'll end up with us. And we've had a number of cases over the years.
And they also want to put a stent in pediatric age group, and which is a big problem.
Yes. Your comments, Deepak?
So the main thing I would say is anyone who is intervening in a child needs to realize you're making an intervention which will affect the child for the rest of their lives, which might be another 60, 70, 80 years. So the child will carry your legacy of what you have done to that child, whether you have done good or bad. So before you do anything, you need to think twice. Am I doing the right thing for this child? It is very important. If you start off doing things for the wrong reasons, then you're going to cause damage. And this child is going to suffer for the rest of their life because of that one thing you have done wrong. So before you do anything, think twice what you're doing. And now there is enough expertise around the country that you can ask for help. Even I ask for help. Even if I have a difficult case, I will call a few people to say, what do I do about this? There's nothing wrong, no ego issue, nothing like that. If you ask for help, if you ask for advice, what would you do in this particular case? Because your actions will matter on these kids. So you have to be extremely careful what you're doing on these kids.
I think on that note, we'll probably reaction from Arpit. Arpit, have you seen cases like this which have, inappropriate treatment? All of us have complications. Of course, we will get it as long as we keep working. But the wrong instrumentation, wrong choice of intervention, etc. Anything that you haven't.
Subglottic stenosis because of the overuse of lasers, I have also seen very frequently.
You've seen.
I think, yeah.
Especially in the pediatric age group, it's disastrous. Yeah, and Shashi had presented a lovely paper on the use of T-tubes. No, nothing wrong with using a T-tube, but many of those cases probably could have, been treated appropriately. Am I right, Shashi? In Lucknow, you had presented this.
Yes. Why our progress is limited? Because we are using too many T-tubes. That was the
totally agree with it.
It was a nice study. Amarnath, Dr. Amarnath, do you want to say something?
I've seen cases where the excessive use of laser has been done.
Again,
when I refer them to the higher centers like you are more, I've seen better results have come up.
Thank you for your kind words. But basically, all of us should know there will be complications. And I remember one of our patients, I think it was Tanveer, who had sometimes this happens in big institutions, like Shashi said. No aspersions on them, but there has to be self-policing, and then there has to be peer pressure. But when it crosses boundaries and we're talking about other specialties, it becomes a little more difficult because I think that's a challenge that we have to face for larynxes which have been totally damaged due to inappropriate. I just wanted to highlight this towards the end of our talk. And excellent. Thank you very much for your help, for participating in today's discussion. Thank you, Vijay, for giving us this opportunity. And President of the IAOHNS, Dr. Gautam Kond, for giving us this time and extra time too. So Amarnath, thank you. Thank you, Arpit. Thank you, Shashi. Thank you, Gautam. Usually I don't thank Deepak because I keep thanking him all the time.
Thank you very much. I think
Thank you very much. Have a good evening.
So on behalf of IAOHNS, I would like to place my sincere thanks to this entire faculty who has joined for this live webinar discussion on this Sunday evening, sparing their family time for teaching and sharing their knowledge with us. And also would like to thank the participants who are nearly 500 across India, who are really encouraging us to do more programs like this. I'm sure this topic can be discussed for a whole day, not just extra half an hour. And our moderator, Dr. E.V. Raman sir, who has a vast experience in this field, has clearly got the most possible and practical messages on this contemporary trends in the management of pediatric airway from all the faculty who are key opinion leaders in this field. I would also like to place my sincere thanks to Dr. Deepak Mehta from Texas Children's Hospital, USA, who immediately accepted our invitation for participating on this Sunday morning to share his tremendous amount of his experience on this pediatric airway management. So I would also like to thank GSK, especially Mr. Keshav Shankar and their team who are working behind this program to help spreading knowledge, which is the main aim of Indian Academy. Those who are not members of IAOHNS, I would like to welcome all to be part of IAOHNS by becoming a member of IAOHNS. So you can download the membership form from our website iaohns.com and send it to us. Next program is going to be in the month of July, in another weekend with different interesting topic on management of thyroid disorders with the interdisciplinary team. And I would like the participants to visit iaohns.com for the update. And also I would like to welcome you all for our 8th annual conference, Indian Academy of Otorhinolaryngology Head and Neck Surgery, IAOHNS 2022 on 25th, 26th and 27th November at Nagpur. And we have Dr. Madan Kapre as organizing chairman and Dr. Samir Chowdhury, organizing secretary, who are doing excellent work on the scientific program. And we will be happy to part of this program. So welcome you all to IAOHNS 22, Nagpur. With this, I would like to conclude this session. Thank you all.
Vijay, one last minute. I'll be failing in my duty if I don't thank my entire team, especially Deepa, who's helping me out with all the slides and presentation. She's an active airway surgeon now, a young person who's a lot of passion with the pioneering work in ultrasound. So thank you, Deepa, for helping us.
Thank you. Thank you, sir.
Thank you. Thank you.
Hey, thanks, Shashi, for being with us.